Okay, during the webinar, I would like to ask the panelists who are not in action to mute themselves and to stop their camera. We are on the YouTube now, and we're going to start in the next 3 minutes.
Did you find Dr. Mohammed Abdurraouf?
I think he's here now. I make him co-host now,
Yes.
and I make him, Prof. Jamal, I think you are co-host already. مساء الخير يا بروف، ازي حضرتك؟
الحمد لله.
زي منورنا والله، يعني احنا ما شاء الله عليك. ربنا قالوا لي البروف تعبان شويه ده كده تمام قوي، ما شاء الله عليك يعني.
الحمد لله على السلامه يا دكتور محمد.
الحمد لله على
القرن
السلامه.
ده اللي جابنا ورا يا باشا.
لا يا باشا، لا ازاي بقى، احنا
نورتنا وشرفتنا. الف سلامه
الحمد لله على السلامه.
الحمد لله على السلامه، كويس ان احنا طمنا على حضرتك.
الحمد لله على سلامة حضرتك.
يا رب.
الحمد لله على السلامة.
ربنا يبارك فيك. ايوه كده، يعني شوف حضرتك لو السكرين بس. ايوه لو ايوه تمام
كده تمام.
يبقى بس في حته كده باينه فوقنا كده. تمام
كده كويس.
وكمان مره الف مبروك رئاسه الاسم، يعني متاخره شويه بس الف مبروك. احنا باركنا على الميجا، باركنا لحضرتك على الميجا ويب سايت، على الميجا فيسبوك.
متشكر جدا، الله يخليك.
ربنا يبارك فيك. ربنا يبارك فيك. We are nearly 100 people now. Prof. Ilyas Kamil is with us actually. Wow, that's fantastic. Yes, okay. Prof. Ilyas Kamil is the panelist now. Prof. Ilyas Kamil is always supporting us. Everybody knows who is Prof. Ilyas Kamil, and I'm so honored that she is with us tonight.
Dr. Ilyas Kamil is our role model.
أيوة.
Not only in obstetric anesthesia but in the whole anesthesia practice يعني حقيقة.
تمام يعني ما شاء الله عليها. And she never leave us alone, and she's always supporting us with the webinar, either here or the MEGA, and we are so honored by such figures supporting that scientific activities.
شكرا جزيلا يا دكتور متسو، شكرا جزيلا لكم جميعا يعني.
ربنا يخلي حضرتك.
احنا اللي متشكرين يا دكتورة ايناس على مشاركة حضرتك الدائمة لينا ودعمك لينا دايما.
ده احنا انا اللي متشكرة، والحمد لله على سلامتك يا محمد.
الله يسلم حضرتك.
حضرتك شرفتينا ونورتينا يا فندم.
ميرسي يا اسماء يا حبيبتي.
الحقيقة يعني هنبتدي دلوقتي
in less than a minute.
Okay, just give me.
I will tell you exactly. Okay. Because it will be in less than few seconds. Just to let you know our success tonight, or the advertisement of this webinar, we are attended by 110 colleagues from all over the world, which is absolutely fantastic. I'm so happy with that. And I would like on your behalf thank every single person supporting us tonight. Prof. Mohammed Abdurraouf, all the floor to you. Thank you so much.
I would like to thank all the people who are sharing for such an activity. We start our monthly scientific activity. We restart our activities again this year. I'm honored to be the head of the anesthesia department. We start with obstetric anesthesia. Usually we rely on our professors and our colleagues from Cairo University, but this time we are happy that Professor Dr. Gamal Lotfi from Al-Azhar, Professor of Anesthesia and Intensive Care from Al-Azhar University and Nasser Institute University, is going to share his experience. We are open-minded. We have to expand the knowledge from everywhere in the country, even from everywhere of the world. So I would like to thank Dr. Asmat Abu Rigal and Dr. Magid Salah and Dr. Nassim Rifai for their great effort in organizing such activity. And I'll keep the phone for Dr. Asmat to start this scientific activity. And thank you.
Thank you, Dr. Mohammed Abdurraouf. We are honored that you start our scientific day. thank you for your support. I'm Dr. Ismat, the head of anesthesia of Cairo University. I would like to thank all my colleagues who shared in the delivery of this event. Actually, while organizing this webinar, especially the interactive session, the three doctors, Dr. Mai, Dr. Alia, Dr. Fahima, were very active and even proactive to search in references and to bench our work with what has happened and reviewed internationally about Marfan syndrome in Caesarean section. They were very patient to review and add and omit from the slides. Together, I thank them for their patience and their of course, effort. Another thing, I would extend many thanks to Professor Dr. Nesreen. She is always supporting the obstetric and the gynae department, anesthesia department in Qasr Al Aini Hospital. And I would like to extend also my thanks for lecturer Dr. Samir for helping with us. And keeping the best for the last, finally, we are honored to have with us today Professor Dr. Yamal, who will be sharing with us tonight with a very important, nice lecture. We are honored for him to share us. So I will be glad to moderate and introduce our speakers. And we will start by Professor Dr. Gamal Lutfi, Professor of Anesthesia and Intensive Care and Pain Management at Al-Azhar University. He is the head of Intensive Care Unit at Al-Azhar University Hospital, and he's a consultant of anesthesia and intensive care at Nasser Institute Hospital. He is going to tell us today a very nice lecture about anesthetic implication of hysteroscopy. So, Professor Gamal, please, you can start.
First of all, I would like to thank my dear colleagues and dear Professor Dr. Muhammad Abdul, the head of the Anesthesia Department and ICU at Qasr Al Aini, and Professor Dr. Maged Salah, Professor of Anesthesia and Intensive Care and Pain Management at Qasr Al Aini Hospital, and Professor Dr. Nesreen Rifai, Professor of Anesthesia and ICU Pain Management at Qasr Al Aini. I would like to thank the Professor Dr. Ismat Hijazi, the organizer of this meeting. I am a great pleasure to be here and my colleagues and professor in Qasr Al Aini University. My topics today, we start the anesthetic implication of a hysteroscope. I will try to cover this point, the incidence, the classification, and the complication of the hysteroscope. What is about the distending median, the mechanical factor, and the effect of electrocauterization, anesthetic complication, early and late complications. Bentonelli has the first man who discovered the visualization of the uterus since 1869. It is minimally invasive technique, diagnostic and therapeutic approach for the, it is consists hysteroscope of viewing the system for illumination and endoscopy, and distending medium for the visualization, and another instrument for aspiration and the removal of the septum or colon. This is a picture of the hysteroscope, as we mentioned, is illumination system and the distending medium and another instrument for the removal of the polyp or the septum or adhesion. What is the types and the indication of the hysteroscope? First of all, it is diagnostic for unexplained vaginal bleeding and localization the site of the missed intrauterine device, investigation the causes of abortion and infertility, surgical hysteroscope for the removal of endometrial ablation, excision of the polyp or fibroid, removal of the septum, and adhesion. A choice of anesthesia for the hysteroscope depends on the patient preference. If the patient refuses regional anesthesia, can get the general anesthesia. The length of operation for the short diagnostic procedure, it needs a simple technique. If laparoscopic accompanied by hysteroscope, we need long term of anesthesia, general anesthesia with intermittent post-pressure ventilation and muscle relaxant, day surgery or day surgery, and the medical fitness of the patient can determine the types of anesthesia. Types of anesthesia for hysteroscope from the general anesthesia. As we mentioned, for short diagnostic or outpatient, we use propofol, oxygen nitrous oxide, and inhalation anesthetics, short acting. And we use total intravenous anesthesia with propofol infusion, face mask with laryngeal mask for the diagnostic and simple procedure. But for surgical hysteroscope, we need general anesthesia with endotracheal intubation and post-pressure ventilation with full monitoring and muscle relaxation. Types of anesthesia on regional anesthesia, either neuroaxial anesthesia, spinal or epidural anesthesia. Sensory level should be up to T10 for adequate anesthesia. The advantage of regional anesthesia, the avoidance of post-operative nausea and vomiting. In addition, local anesthesia may be paracervical or intracervical block or topical anesthesia of the uterus or simple infiltration may be sufficient for the short-term procedures. What is the complication of the hysteroscope? What is the main issue in these topics? Complication related to the patient position, complication was the vasovagal attack from severe pain, anesthetic complication, the complication related to the endometrial axis or cervical trauma, uterine perforation, intraoperative bleeding, terminal injury, gas or air embolism, which is fatal in such situation, and the problem of distenting medium and the fluid overload. Post-operative complication of hysteroscope started from the early post-operative, from infection and post-operative bleeding, or late complication from persistent complaint or intrauterine adhesion or hematometria, or uterine rupture in subsequent or the following pregnancy. What is the complication of hysteroscope can be summarized according to the ABC. A or air embolism, B bleeding and perforation, C cerebral edema from the dilutional hyponatremia, and this E electrolytes imbalance, most important dilutional hyponatremia, fluid overloaded from hysteroscope syndrome, I will be discussed later on, gynecologic and obstetric complication from the bleeding and infection and hematometry. Again, this is the complication most common: perforation, bleeding, fluid overload, infection, and hematometry. Patient position, it is very important issue during the hysteroscope. Lysotomy position carry much risk for the nerve injury. Modified lysotomy position, it is ideal position, just moderate hip flexion with limited abduction and external rotation. It is very suitable in such situation. Incorrect position carry the risk for the nerve injury, as we mentioned, back injury or back pain or damage to the soft tissue. What is important, the compartmental syndrome of the lower limb, and deep vein thrombosis DVT, which is a serious situation. This is a nerve which can be affected during the abnormal position started from the sciatic nerve, femoral, obturator, peroneal, or saphenous nerve. The compartmental syndrome in the lower limb as wrong position. It is the pressure on the muscles of the osteofascial compartment lead to ischemia and later on the reperfusion injury. The sequence will be the rhabdomyolysis, permanent stability of these muscles. This event, it is facilitated by leg holder and the pneumatic compression of stocking or any direct pressure to the lower limb during the procedure, especially for a long time. The risk reduction and how to manage these problems, you have to stick to ideal lysotomy position, moderate flexion, with limited reduction and external rotation, limited abduction and external rotation. You have to avoid push pressure in the prone area. You have to avoid leaning on the side of the patient during the procedure, which is a serious complication. Early identification and management of this compartmental syndrome. Distending medium and the problem of the complication of distension medium. Distension media or distending media, it's either liquid or gas carbon dioxide, or liquid. We can classify it into high molecular weight distending medium, dextran 32%, or low molecular weight, either classified to electrolyte and non-electrolyte. Electrolytes in normal saline or ringer lactate, or non-electrolyte glycine 1.5%, sorbitol 3%, mannitol, and dextrose. Low viscosity media, which is electrolyte free, as we mentioned, glycine, sorbitol, mannitol, glucose 5%. It is used in diagnostic hysteroscope, used in operative hysteroscope using mechanical. We can use monopolar resectoscope or cauterization. Low molecular weight glycine. Glycine, it is inhibitory neurotransmitter in the brain. It is a simple amino acid that mixed in water and supplied in 1/3 liter of bag. The advantage, it is non-electrolytic, hypoosmolarity, it is about 200 millimole per liter, non-hemolytic and non-immunogenic. The intravascular absorption syndrome occurs with the high low molecular weight distending medium mean glycine, more in premenopausal woman. Why? Because the female sex steroid hormone, it is inhibits sodium potassium ATPase pump with water and sodium not throughout of the cells and lead to the brain edema. Gonadotrophic hormone agonist inhibits such hormone action, may prevent this complication to be occur. High viscosity medium complication started from the allergic reaction, non-cardiogenic pulmonary edema, high output left ventricular failure, coagulopathy, impaired platelets function, hemodilution of fibrinogen, decrease factor 5, factor 8, and factor 9. Low viscosity medium will lead to the most serious complication, what is called hysteroscope syndrome. Hysteroscope syndrome, the component is volume overload, hyponatremia, hyperglycemia, hyperammonemia, and hypothermia. Manifestation of the hyponatremia according to the serum sodium, which is very serious complication due to the absorption of the hypotonic solution. Serum sodium 120, it manifested the cardiovascular or CNS manifestation. The cardiovascular widening of the QRS complex or CNS restlessness and confusion of the serum sodium 115, widening of the QRS complex and raised ST segment, nausea and soreness, disturbed level consciousness. If the serum sodium below 110 will develop ventricular tachycardia and ventricular fibrillation, later on seizures, convulsion, and coma. What is the glycine? Intraposition of glycine, what is happening? Glycine, when intraabsorbed intravascular, produce the volume overload. Volume overload lead to the hyponatremia. Hyponatremia lead to hypoosmolarity. Hypoosmolarity lead to the cerebral edema. At the same time, the volume overload to hypertension. In addition to the hypoosmolarity, produce left ventricular failure and pulmonary edema. Hypoosmolarity lead to the hemolysis, the rupture of RBCs, and anemia. Glycine, also hyperglycemia, metabolized into ammonia, lead to hyperammonemia. Hyperammonemia lead to encephalopathy, and lead to confusion, nausea, and vomiting, and coma. What is the hyperglycemia? Hyperglycemia, as you mentioned, glycine, it is neurotransmitter in the brain, similar to GABA in the brain, spinal cord, the retina. The benzodiazepine used for treatment convulsion through activation of retina GABA receptor may be compromised vision. So the glycine increase the effect of N-methyl D-aspartate excitatory transmitter and lead to encephalopathy and seizures in such patients. Hyperglycemia, magnesium exert a negative control in N-methyl D-aspartate, so hypomagnesemia in addition to hemodilution will lead to increased convulsion or seizures. So magnesium and ketamine are NMDA antagonists, thus may be tried for the treatment seizures or convulsion caused by hyperglycemia. Hysteroscopic syndrome, what is the definition? It is intravascular absorption of hypotonic irrigation fluid with subsequent hypotonic hypervolemia and hyponatremia. This syndrome, it is similar to URB syndrome in men, which physiologists recognize the problem of intravascular fluid absorption as URB in men. Hysteroscopy is similar to the URB. Two routes of fluid absorption in the intravascular volume through the endometrial vein or through the fallopian tube. The endometrial vein through the high pressure route of absorption due to the intrauterine pressure. It is more than the mean arterial blood pressure, or the low pressure from the open the blood vessels during the resectoscopy. What is the factor affecting the absorption and hysteroscopic syndrome? In TURB, the hydrostatic pressure at the prostatic bed, it is reported to about 70 millimeter mercury. The duration of surgery should be limited to 1 hour and size of the prostate. But in the hysteroscope, the level of intrauterine pressure, we know that the uterus it is non-compliance. When the flow of the fluid irrigation fluid, the pressure may reach about 7 to 100 millimeter mercury. The level of mean arterial blood pressure, the patency of outflow challenge during the distending medium, the penetration of the uterine or instrumentation or the opening of many sinuses or vessels. How to limit the severity of the intravascular syndrome? You have depend on the amount of fluid absorbed. As much the fluid absorbed, it is the syndrome will be developed. Later on, the number of the vascular open sinuses, the duration of procedure. If the duration of the procedure extended, the syndrome will be occur. The flow pressure, it can be present intra and post-operative. Intravascular absorption syndrome can occur during intraoperative or immediately post-op. This figure shows the circulatory absorption create a pressure gradient between the blood and the brain cells. As we mentioned, the brain cells, this can be overcome by pumping action of the cells in the blood through the sodium-potassium ATPase, but woman brain deficient in such mechanism, so the water will be retained inside the brain cells and reduce cerebral edema. How to prevent the gonadotrophic decrease the volume systemic absorption distending medium? Dilution of vasopressin immediate before cervical dilatation, 8 ml or 4.21 ml of vasopressin deeply injected at 4 and 8 o'clock in the cervix will be decrease the absorption of the fluid during procedure. Intraoperative fluid management problem. Before the resectoscope, we have to take baseline serum electrolytes, sodium and potassium. Women with cardiopulmonary disease should be evaluated carefully for the fluid balance for the shift of the fluid volume, operating usually at the lowest effective intrauterine pressure. Pressure should be from 50 to 80 millimeter mercury always to try to keep the intrauterine pressure below the mean arterial blood pressure in order to decrease the intravascular absorption of the fluid. Completing the procedure as quickly as possible, you have to measure the fluid inflow and fluid outflow in closed system, precise the calculation of absorbed fluid. You have to use the bulk vaporizing electrode, which reduce the systemic absorption compared to the section group. It is more greater coagulation, more greater collateral sealing of the vessels. Deficit of the fluid should be calculated. If the deficit reaches the predetermined limits, depending on the patient baseline status, could be around 750 and to 1,500 ml. The serum electrolyte should be measured. We have give furosemide from 10 to 40 milligrams, depending on the renal function. You have to termination of the procedure of the serum sodium decrease below 125 milliequivalent per liter, or if the deficit it is more than 1.5 and 2,000 milliliter of glycine. And if you use normal saline, the volume can be doubled in this situation. Normal saline 9% sodium, it is safest, widespread availability, low operative cost, physiological disposable by peritoneal absorption, but at the same time, excessive vascular absorption lead to fluid overloaded and pulmonary edema. It is not suitable for the monopolar. It is a good conductor for the electrons. It has dispersion of the light, can use, but it is not suitable for the surgeon. It is more suitable for anesthetist, but not for the obstetrician. Gas embolization of the use the carbon dioxide as a distending medium. A lot of complication can be occur. Gas embolization, carbon dioxide or respiratory acidosis, arrhythmia, and cardiac arrest. Symptoms and signs started from the acute circulatory collapse, unexplained hypotension, tachycardia, and desaturation, meanwhile murmur, and sudden increase intravenous pressure, abrupt decrease of the end-tidal carbon dioxide, and you can withdrawal of the air from the central venous pressure if you apply preoperative. The treatment management stop the procedure, stop use of the nitrous oxide. We give 100% oxygen. We change the patient left lateral position into Trendelenburg position and try for aspiration of the gas, which it is fetal condition if it is occur. Precaution to prevent carbon dioxide or air embolization. You have to avoid Trendelenburg position, remove last dilator just before inserting the resuscitation, minimize the cervical trauma, limit repeated removal and reinsertion of the resuscitation, maintaining the intrauterine pressure below 100 mm mercury and the flow rate below 100 liters per minute. The assistant must keep a watch on the fluid bottles and inform surgeon before changing it to prevent any bubbles on the uterus with care. Vaporizing myoma limits the need to remove the fibroid clip. The injection of intracervical vasopressin block gas from entry into the circulation. What is the management of the carbon dioxide or air embolization? It is occur with head low position with Trendelenburg position, 100% oxygen, insertion of central venous catheter, and trial to withdrawal of the air, and may require cardiopulmonary resuscitation. Anesthetic consideration for hysteroscope, preoperative assessment, history examination very beneficial. Choice of anesthesia, monitoring, standard ECG, blood pressure, and tidal pulse oximeter, CVB, especially for surgical hysteroscope and cardiac output, core temperature in the lengthy operation. Monitoring of the fluid, it is very important. Automated system or rough measurement is the inflow and outflow, xenol tagged irrigation fluids, clinical assessment, pulse, blood pressure, and central venous pressure, laboratory hemoglobin, hematocrit, blood gases for respiratory acidosis, sodium for development of hyponatremia. Prevention of hysteroscopy syndrome. You have to limit the pressure to 6 to 70 millimeter mercury, never exceed 100. Limit the time to 1 hour. Regional anesthesia, it is better. Limit render impaired position to minimum to avoid air embolization. Electrosurgical hysteroscopy with physiological medium, it is very important. General guideline consideration during the hysteroscope. 500 ml deficit, you have to measure serum electrolytes. 1,000 liter deficit, 1,000 milliliter deficit, furosemide, give furosemide intravisa and check sodium potassium again. 2,000 milliliter deficit, you have to stop surgery and suspect hyponatremia and aggressive management if it is occur. Treatment of the hysteroscope syndrome, you have to stop surgery, furosemide, 20 milligram intravenous oxygen. Treatment of the pulmonary edema developed by intubation endotracheal tube, post-pressure ventilation with PEEP, invasive blood pressure monitoring and central venous pressure, arterial blood gases for management of respiratory or metabolic event, and serum sodium. Treatment of the sodium correction of the hyponatremia developed. The important to correct sodium deficit, it is equal to total body weight multiplying 1/4, multiplying 125 minus present sodium. According to the symptoms, mild symptoms, you can correct the serum sodium 0.5 milliequivalent per liter per hour. If the patient with developed severe moderate symptoms, you can correct up to 1 milliequivalent per liter per hour. Severe symptoms, you can correct up to 1.5 milliequivalent per liter per hour. In severe cases of the hyponatremia, serum sodium less than 120 and severe cardiovascular and neurological manifestation, hypertonic saline, it is indicated. We start 100 ml per hour. Rapid correction of the hyponatremia can produce serious complications, central pontine demyelination. Again, if the patient develops convulsion, you have to give anti-convulsion and diazepam or benzodiazepine barbiturate. Ketamine, dexmedetomidine, alpha-2 agonist inhibit N-methyl D-aspartate receptor, and you have to suggest in the treatment of convulsion. Blood transfusion for anemia from the hemolysis RBCs as a result of the hypotonic irrigation fluid. Conclusion, hysteroscope surgery, it is safe and effective. Specific risk due to distension medium and surgical technology used. Most new technologies avoid the use of non-ionic distension medium, and hence many of the complication, it is the fluid overload. To minimize the risk of complication, appropriate case selection, recognition of the learning phase. The operator should be learned and diagnostic for 500 cases before the operating hysteroscope. Patient with surgical team operations, knowledge the distension medium, what is the low viscosity and high viscosity and the complication, knowledge the hysteroscope equipment use. The surgeon skill remains the best safety measure in the operative hysteroscope. Thank you very much.
Thank you, Dr. Gamal, for this very informative lecture. And we can now open the field for questions and answers. 5 minutes, please.
Dr. Asmat, can I add a comment, please?
Of course. We are honored.
It's very common. The following discussion occur between the surgeon and anesthesiologist. Usually the surgeon is senior and the anesthesiologist sometimes junior. So the surgeon tell the procedure will take less than 2 minutes. You can give a patient a face mask. And some of our junior colleagues do hysteroscope using a face mask. So please, this is completely prohibited. And for any patients undergoing hysteroscope, he should be intubated and ventilated. It is a must because all of such complications, if happened, it's better to be managed with an intubated patient. And sometimes the surgeon give plenty amount of fluids and the patients enter into pulmonary edema. So this can be managed betterly with an intubation. So my message, it should be a clear message. Any hysteroscope patient should be intubated. Thank you.
Thank you, Dr. Mohammed, for your comment. And if anyone would like to have a question, we have 5 minutes for question, and Dr. Gamal and Dr. Mohammed will answer you. We were having 3 at least of the participants raising hands during the lecture. So now is the time for the questions, please. If anyone would like to have a question.
Ojo, you can talk. The first one, Dr. Ojo. Are you happy to talk?
Would you like to put your question in verbal, talking to us, or writing?
Okay. Dr. Wael, Dr. Walid, Dr. Wael. Dr. Walid. Dr. Walid, okay. So I think we will not need to waste the time.
Yeah, hello? Hello?
Yeah, hello?
Yeah, I just have a concern regarding our colleague recommendation about, I think he was saying that for all hysteroscopies, it should be endotracheal intubation, but I believe if it's just the diagnostic hysteroscopy, there is no need for intubation.
I would like to recommend on him again, even if it's diagnostic, even if it's a very short procedure, from the safety point of view, we should intubate every patient. This is my opinion. And again, I'm dealing with a lot of stuff. If this is your experience, you can do it yourself. But if you are talking about the whole department, this should be a must to intubate every patient for hysteroscope for the safety of the patient.
Yeah. What's your rationale for that, sir?
My rationale that even if it's diagnostic, you can get air embolism. So if air embolism happens and sudden cardiac arrest happened, it's better that the patient be intubated. You cannot say that air embolism will never happen. A lot of serious complications might happen. And again, surgeons don't, especially obstetricians, don't know the exact amount of fluid they are injecting. It's not like urologists. Urologists are a little bit more aware, but obstetricians usually less aware. So from the safety point of view, fluid overload is not uncommon even in minor diagnostic procedures.
If you don't want, just comment, Dr. Mohammed, if you don't want to intubate, we can give spinal anesthesia. That's the best. It's the same as TURP. So for spinal anesthesia, when the patient has spinal anesthesia, we can diagnose the syndrome early by dizziness and hallucinations and CNS disturbance.
Dr. Desir, if you are giving spinal anesthesia, this is accepted. But I mean, if you are giving GA, general anesthesia,
you have to intubate, sure.
Okay.
I've seen a case in our university hospital when the patient developed severe pulmonary edema, hyponatremia, sodium was 97, which is incompatible with life, and severe ventricular arrhythmia within 15 minutes. When we reviewed the fluids used by the surgeon, he said only 9 bags, but the bag was 3 liters. So he used 27 liters under pressure distilled water within 15 minutes, and the patient was about to arrest.
Dr. Kamal, please.
I have comment, Dr. Abdurraouf. I am agree that the procedure, the time of the operation can be determine the types of anesthesia. Regional anesthesia can be accepted, either spinal or epidural. If the patient it is accepted, it is very beneficial. You have to monitor patient; it is fully awake, and if it is having such mishap as ear or gas embolization, it will be occur and resuscitation at them. But for the prolonged and surgical hysteroscope, as you mentioned, you have to full controlled and general anesthesia with intratracheal intubation with deep full monitoring as well.
No, my point is, if you are giving general anesthesia, and even if the surgeon telling you it's a very short procedure, it's diagnostic, I'm insisting here that we have to intubate. If you are using regional anesthesia, this is accepted. But if you are using general anesthesia, my policy, you should intubate. This is for more safety.
Yes, I am agree 100% for the possibility for development of the intravascular absorption and pulmonary edema in the period.
Professor Dr. Tariq Abdelbari, do you have a comment? Dr. Tariq?
No, he tried to I let him to talk. Prof. Tariq, can you talk, please?
I think you can hear me now, right?
Yeah, I will hear you now.
Yeah.
Okay. We have to differentiate between diagnostic procedures and therapeutic procedures. As for diagnostic procedure, this is just a few minutes procedure. And it's either done by using spinal anesthesia, which is the best for sure, or if we choose general anesthesia, laryngeal mask airway is more than enough for this short procedure. As for surgical hysteroscopy, definitely can be done under regional anesthesia because we have a time limit, and the time limit is 1 hour. So spinal or epidural will do the job. And the most important thing is that the fact that the anesthetist must be fully aware about the complications of the procedure and has to anticipate the complication before it occurs. So he has to keep an eye on in and out of the fluids, on the hemodynamics and everything. So in order to prevent the occurrence of the problem. If general anesthesia, it's okay, but I would rather prefer regional anesthesia, whether this is done under, whether the procedure is diagnostic or surgical. As for intubation, I personally do intubation if the patient refuses and if it's a therapeutic. But I don't insert endotracheal tube for diagnostic procedure, and I don't give muscle relaxants for diagnostic procedure if it is under laryngeal mask. It's just a very simple procedure. It doesn't take long. It's just a few minutes. So it's just 5 or 10 minutes. So if I'm going to give a muscle relaxant, I'm stuck with the patient for another half an hour for nothing. Thank you.
Thank you, Dr. Tariq. Any more question in this lecture, please?
Dr. Asmat, we have to put a consensus in our department that every patient to be intubated if we are going to use general anesthesia. Dr. Tariq Abdelbari has a great experience, so we cannot transfer his great experience to our junior staff. So it's our protocol. I think for the safety, we should intubate.
Then we can come a conclusion from all this that if we choose regional anesthesia, it's okay, but when complication arises, we can then treat after we intubate the patient. Or if we start from the beginning, as Dr. Professor Mohammed Abdelraouf said, general, so it's better to be a tube, not LMA, for safety and for interaction to any complication that may arise. So thank you for all the opinions, and we need really to move because we have a full schedule to the next lecturer. So if anyone has another comment, only one more question and we will shift next speaker, please. Okay, so I think we can now ready for our next speaker. Our next speaker is Dr. Ahmed Samir Saad. He's a lecturer of anesthesia at University Hospital, and he will think it will be a good preparation for Caesarean anesthetic management. Dr. Ahmed, you can start. You have after your lecture. Start, please. Dr. Ahmed, you can start.
Okay, thank you very much. It is a great honor to be with you today and to give this lecture. I wish it will be valuable to some extent. It is a very interesting topic. This category of patients, pregnant patients with cardiovascular diseases.
Would you be kind just to start the slideshow, please? Slideshow. Thank you so much.
Okay. As I said, this category of patient, we meet this category of patient every day, and it is of a great concern to us as an anesthetist. Cardiovascular disease is a major cause of maternal morbidity and mortality worldwide. Maternal heart disease comorbidity it occurs in about 0.2 to 3% in all pregnant women. We may notice that cardiac diseases with pregnant women has increased in recent decades, and this may be related to some things, mainly the good management of congenital heart diseases. Many patients with congenital heart diseases are treated right now, and we may see them leading a good life, and they may even get pregnant. And so they come to us, and we should deal with these situations. Also, we may find ischemic heart diseases. I know some of you may say ischemic heart diseases, it usually occurs in ages older than the age of childbearing period. But recently, many women delay the decision for getting pregnant. And so we may see patients with ischemic heart diseases right now getting pregnant, and we should deal with pregnancy with ischemic heart disease. As we are talking about cardiac disease in pregnancy, we should learn two things. The first of them is the physiological burden that pregnancy places on an already compromised system. As we know, there is some physiological changes that occurs during pregnancy, and these physiological changes may worsen compensated heart, so it may become decompensated. Also, we should know the pathophysiology of every kind of these diseases to know what we should deal with. Management requires a multidisciplinary approach. It may require, of course, an obstetrician, anesthetist, and a cardiologist. And the decision should be made early. There should be a recommendation from and follow-up of the patients from day one in pregnancy. Even the decision of getting pregnancy itself should be taken after recommendation. As we will see, some patients have a great risk if they get pregnant, and they may be recommended not to get pregnant. We will see this category after some slides. So now, what is the physiological changes that occurs during pregnancy and may affect the heart of our patient with that disease? Intravascular volume increased by 50%, and the peak increase usually occurs during the third trimester of pregnancy. And as we know, this increase in the volume, of course, it is associated with increase of the burden on the heart. This volume usually, that increase leads to dilutional anemia. Also, we will find that platelet count also decrease. But this is accompanied by increase in coagulability. So pregnancy is considered as a hypercoagulable state. This patient, as we may see, have increased in coagulation factor number 8, 9, and 10. And this increase in hypercoagulability, of course, may lead to DVT and pulmonary embolism. And even the most mild cases of pulmonary embolism in a normal patient may be of great concern in a patient like our patients with this cardiovascular disease. Also, we will find that cardiac output increased by 20% in the first 8 weeks. And most of that increase is due to vasodilatation. As we know, pregnancy decreases the systemic vascular resistance, and this decrease in the systemic vascular resistance usually increase the amount of blood that ejected from the blood, as there isn't a great resistance against it if vasodilatation occurs. Also, in pregnancy, heart rate increased by 10 to 20 beats per minute, and this may be a load over a decompensated heart, especially if our patient is with a stenotic lesion or ischemic heart disease. The heart also developed what is like a dilated cardiomyopathy picture, but it usually accompanied with increase in contractility. The heart dilates, but the thickness also increase. The thickness of the ventricle also increase. So usually the end diastolic pressure is maintained. Also, the gravid uterus may inhibit the venous return and reduce the cardiac output. As we know, when our patient, pregnant patient, lies flat in supine position, the gravid uterus may compress the inferior vena cava, and this may lead to decrease venous return to the heart, and this decrease may be great, even up to 25% of the venous return. Also, during labor itself represents a great burden on heart. As during labor, as we know, cardiac output increase. Also, the patient is asked to strain. This Valsalva maneuver decrease the venous return and may decrease the preload. Even the contracting uterus squeezes blood. It may squeeze up to 500 milliliter into the circulation. And this may lead to a load on the heart. Also, uterine contraction increase the preload and afterload. Also, the postpartum period, there is a massive transfer of fluids from the extravascular space to the intravascular space. The fluid which was in the extravascular space may return to the circulation, and this may be a load over the patient. So our patient must be well monitored during the postpartum period, as there may be a heart failure or something like this. Now we are with risk stratification. Risk stratification is very important because we should deal with every patient according to his kind of disease, and we should know who is the patient is at a great risk, because this patient, we should put him in a great facility tertiary hospital or something like this, and should manage him with a different management or give him more care. We have some studies for risk stratification. We will talk about them. The first one is CARPREG-1, CAR for cardiac, or PREG for pregnancy, and also CARPREG-2. Zahara, it is a German study. We will talk about this name afterwards. The first one is CARPREG-1. Here's the risk factors. We have the risk factor prior cardiac event or arrhythmia, or this is given 1 point. I am sorry, but I think the point is behind our photos. So prior cardiac event, it is given 1 point. New York Heart Association class more than 2, it is also given 1 point. Left heart obstruction, it is given 1 point. Systemic ventricular dysfunction, ejection fraction less than 40%, it is given also 1 point. Then the total score is 0, 1, or below 2. I think here the risk score is written, but it is behind the screen. CARPREG-2, we will see here prior cardiac event or arrhythmia. It is given 3 points. New York Heart Association class more than 2 or cyanosis. We know New York Heart Association class 1, this patient has no decrease in his efforts. So he can do all the activities without feeling fatigue. Class 2, as we know, he gets fatigue when doing exertion. Class 3, he gets fatigue or mild exertion, and class 4 at rest. So if the patient is class more than 2, it is given 3 points. If there is a mechanical valve, it gets 3 points. Ventricular dysfunction, 3 points. High risk left-sided valve disease, 2 points. Pulmonary hypertension, 2 points. Coronary artery disease, 2 points. And so then the total score, we gather these points and get the score. If it is more than 4 points, it is the risk of the cardiac complication is 41%. Now Zahara, it is a German study. So it's a German name. I don't know German, so I can't read it. But they took the letter of starting every word, and they get the name, which is Zahara. It is also a risk stratification. Here is the points, and when we gather it, we get the risk of the cardiac complication here. And so we may know who patient is at a great risk, and then we can transfer her to a greater facility or a tertiary hospital. Now, this is WH classification. I think this is, in my opinion, this is the best between all the classification, because it is directed to the point. Here, this patient, the category 1, no detectable increased risk for maternal mortality and no or minimal increase in maternal morbidity. The patient with uncomplicated mild pulmonary stenosis and patient with ventricular septal defect, beta ductus arteriosus, mitral valve prolapse. Also here, the category 2, small increase of maternal mortality or moderate increase. And this is category 2 or 3 according to the patient with hypertrophic cardiomyopathy, or repaired coarctation, Marfan syndrome with aortic dilatation, bicuspid valve with aorta less than 4.5 centimeters. Category 3, this category significantly increased risk of maternal mortality or severe morbidity, and expert cardiac and obstetric pre-pregnancy, antenatal, and postnatal care are required. This category of patient include mechanical valve, systemic right ventricle. We know some patient may be born with a congenital anomaly, and during correction, the surgeon may make the right ventricle is responsible for the systemic circulation. So here it replaces the left ventricle, like patient with transposition of the great artery corrections. So this category of patient is considered grade 3. Fontan circulation, we know in Fontan circulation, the systemic venous return is directed directly towards the pulmonary artery. In this patient, we may say there is no right pump. This patient depends mainly on the preload. So the fluid management in this patient is great, and they are also included in category number 3. Unrepaired cyanotic heart disease also in this category. Other complex congenital heart diseases, Marfan syndrome with aorta from 4 centimeter to 4.5 centimeter, and bicuspid aortic valve with aortic dilatation 4.5 to 5 centimeter. Now, this is category 4. I'm sorry, this is category 4, and pregnancy in this category is contraindicated. So patients in this category should be advised not to get pregnant because there is a very great risk to them. This category include pulmonary hypertension severe, Eisenmenger syndrome, systemic ventricular ejection fraction less than 30%, systemic ventricular dysfunction with New York Heart Association class from 3 to 4, severe mitral stenosis, severe symptomatic aortic stenosis, Marfan syndrome with aortic dilatation more than 4.5 centimeters, bicuspid aortic valve with aorta more than 5 centimeters with severe coarctation. Also patient who get peripartum cardiomyopathy before. We know we encounter patients with peripartum cardiomyopathy. This patient should be advised not to get pregnant again. Now, what is our plan in these patients? First of all, it is a multidisciplinary decision. Second, we should choose between vaginal delivery versus cesarean section. Usually, vaginal delivery is preferred because blood loss is less with vaginal delivery. Also, the rate of infection is less with vaginal delivery. But sometimes we may choose cesarean section, especially with very deteriorated patients, like patients with ejection fraction less than 30%, because they can't manage the increase in preload and afterload which occurs during delivery, especially in the second stage of labor. We may also choose what is called cardiac vaginal delivery. Cardiac vaginal delivery, it is a vaginal delivery, but during the second stage of labor, we ask our patient not to strain. We let the uterus to contract and let the PP to get down with these contractions, and then forceps or ventouse is used. Also, all patients with cardiac diseases, otherwise they will deliver through vaginally or through cesarean section, should be monitored well. ECG, 5 leads, pulse oximeter, because we may know that many patients with cardiac disease may get hypoxic. Also, usually we may use invasive blood pressure monitoring, and I think it is a must. Because even in the vaginal delivery, we may at any point need to go to cesarean section, and during induction or building up of an epidural, if it is in place, we are in need to monitor the blood pressure beat by beat. For the measuring of central venous pressure or pulmonary artery pressure, there is no recommendation to be used in every patient. It may be used according to the patient or on individual basis. Also, the monitoring for cardiac output, it is the same. It is not recommended to be used for every patient, but it may be used according on individualized basis. Neuroaxial anesthesia, usually we use spinal anesthesia or epidural anesthesia, but we should take into consideration this mode of anesthesia usually decrease the systemic venous resistance, and this decrease, the decrease in this systemic venous pressure may affect our heart, because it may decrease the filling pressure. Also, it may decrease the perfusion through the coronary arteries. Sometimes we may use systemic opioids. We may use fentanyl, 25 mic every quarter an hour, with a maximum dose of 100 mic in an hour. There is a debate about the using of systemic opioids because it's affection on the fetus. But most of us give the priority to the mother, and also we ask the neonatologist to take care of the baby of this mother. Nitrous oxide is used in some countries, especially Ontonox, but we should consider that it may increase the pulmonary artery pressure. So it may be contraindicated in patients with increased pulmonary artery pressure. Also, we should take care of hypotension during delivery. We should use, according to the case of the patient, we may use ephedrine, but in cardiac diseases, especially if we are in need of patient towards the bradycardic site, phenylephrine may be preferred. And some recent studies also recommend norepinephrine. For cesarean section, we may, if there is epidural in place, we should build it up, but we should build it up gradually to maintain the blood pressure. And if we are going to general anesthesia, etomidate is recommended, and blood pressure should be monitored and cardiac function. And as we said, postpartum monitoring is also recommended, because most of this patient may get heart failure in the postpartum period. As we said, the fluid which was in the extracellular volume may find its way to the intravascular circulation. Now we will talk about every disease rapidly. Coronary heart disease, as we said, recently we may get patients getting pregnant with a coronary artery disease, as they may delay the decision of getting pregnancy. It occurs 1 in 10,000 gravidi have a previous history of coronary disease. And we should know that if myocardial infarction, if happens during pregnancy, it has a great mortality. It may reach up to 30 to 40%. So such patients should get bed rest and nitroglycerin, especially in critical patients. As we know, coronary perfusion pressure equal aortic diastolic pressure minus ventricular end diastolic pressure, left ventricular end diastolic pressure. And as we said before, pregnancy decrease the aortic diastolic pressure as it decreases the systemic vascular resistance. So coronary perfusion may be affected, and this should be considered. Also, pregnancy increase heart rate, and this increase in heart rate decrease in coronary filling time. As we know, the coronary filling occurs during diastole, and increase in heart rate decrease the time of the diastole. So this may decrease the coronary filling time. Also, during labor, cardiac work increases. Our anesthetic consideration, we should avoid tachycardia, so we should perform good analgesia with epidural from the beginning. Intrathecal opioid may be used. Also, we should avoid beta agonists, and if the patient was on a beta blocker, it should be continued. We should also avoid hypotension. We should put invasive blood pressure monitoring. Phenylephrine is used here, not ephedrine, as we know ephedrine may increase the heart rate, so phenylephrine is more preferred. we should titrate our local anesthetic because if we give policies rapidly, this may decrease the blood pressure, and hypotension is not recommended. Also, oxytocin should be titrated for the same reason, because it may cause hypotension. Postpartum monitoring is also very important. Patient with pulmonary hypertension, as we know, mean pulmonary artery pressure. To diagnose pulmonary hypertension, the mean pulmonary artery pressure should be more than 25 millimeter mercury at rest. And as we know, immense increase in volume may lead to high mortality. This is due to the increase in volume may be a burden over the right side of the heart. And so it may worsen the condition of the patient with pulmonary hypertension. So fluid management should be put into consideration. So decrease in systemic vascular resistance may decrease perfusion to dilated and filling heart, as we said before. It may also occur here. Also, hypercoagulability may lead to pulmonary embolism, and patient with already pulmonary hypertension, when she get pulmonary embolism, even if it was mild, it is fatal to her. We should avoid everything that may lead to increase of pulmonary hypertension, like hypoxia. So our patient should be put on oxygen all through. Also, we should avoid acidosis. And if the patient is mechanically ventilated, we should avoid high ventilation pressure. As we know, we may use vasopressors such as epinephrine or norepinephrine, but we should put into consideration that epinephrine and norepinephrine also increase the pulmonary vascular resistance. And some recommend vasopressin as it may increase the systemic vascular resistance without affecting the pulmonary pressure. If we are going to vaginal delivery, we should do it with epidural analgesia. We may use intrathecal opiates like fentanyl, 25 mic. Oxytocin should be also used with caution, as we said before. It decreases the systemic vascular resistance and increase the pulmonary hypertension. And if we are going to general anesthesia, it should be opioid-based. If we have a patient with severe left ventricular dysfunction, as we know, this patient, any increase in cardiac output or in blood volume may lead to heart failure and pulmonary edema. As we know, in pregnancy, oncotic pressure decrease. So these patients are at high grade risk of pulmonary edema. ACE inhibitors should be stopped. As we know, ACE inhibitors are teratogenic, and most of patients with severe left ventricular dysfunction are on ACE, but in pregnant women should be stopped because it may be teratogenic. Patients with a history of previous peripartum cardiomyopathy are a great risk, and as we said before, they should be recommended not to get pregnant again. For the anesthetic management, our aim is normal heart rate. We should avoid hypotension and hypertension. We should maintain contractility. Normovolemia should be maintained, and pulmonary edema, if it happened, it should be managed well with diuretics. And if the patient is ventilated, we may use PEEP. And also postpartum monitoring is very important. If we have a patient with unstable arrhythmia history, as we know, cardiac dysarrhythmia may occur during pregnancy. Most of the patients are tachycardic. Some patients may get supraventricular tachycardia, but we should know most of this arrhythmia doesn't affect our fetus and doesn't do harm to him. Beta blocker may be used, verapamil and adenosine. All are safe, and they may be used if there is supraventricular tachycardia. And if the patient is in need of a pacemaker or in a need of an automated intracardiac device, it should be implanted. But during, if the patient will go for Caesarean section, we should manage these devices well, either by putting a magnet or asking a cardiologist to put it into a mode that is appropriate for the intervention.
Dr. Ahmed, you have
Aortopathy.
5 more minutes, please.
Okay. Rapidly, aortopathy, here is the problem, is the dilatation of the aorta. It occurs usually in patient with Marfan syndrome. And here we are afraid from the patient of suffering rupture. So this patient, we should avoid Valsalva, and this patient should continue beta blocker. And if dissection is suspected, labetalol may be used. If there is a mechanical valve, our concern here is anticoagulation. Vitamin K antagonists are teratogenic, as we know, so patients should stop warfarin and the drugs like this. Low molecular weight heparin may be used, and unfractionated heparin may be used. But as we know, low molecular weight heparin may pass the placenta. Unfractionated heparin doesn't pass the placenta. Regional anesthesia, if it is used, the patient should be not on any anticoagulation for at least 24 hours if he is on therapeutic Kelixan or therapeutic heparin. Opioid also may be used. Postpartum monitoring for bleeding and valvular clotting. If our patient is with mitral stenosis, she is with low fixed cardiac output, beta blocker should be continued, beta agonist should be avoided, cardioversion should be considered. If atrial fibrillation developed, euvolemia should be maintained, good analgesia and pudendal nerve block may be considered. If general anesthesia is considered, tachycardia, especially during intubation and extubation, should be avoided. Patient with aortic stenosis, transvalvular gradient pressure increase over the course of pregnancy due to increased blood volume and decreased systemic venous resistance. Increased transvalvular gradient pressure may be characterized by chest pain, syncope, angina, and poor fetal oxygenation. Decrease in systemic venous return with aortic stenosis may decrease coronary perfusion. We should avoid hypotension and tachycardia. In mitral and aortic insufficiency, this condition improves with pregnancy, and usually it is well tolerated during pregnancy. Neuro-axial anesthesia is excellent choice because it decreases the systemic vascular resistance, and this is recommended. Labor pain, contraction, and surgical stimulation produce increased vascular resistance, which worsens the regurgitation. Patient with right to left shunt. This category of patient is seen in uncorrected tetralogy of Fallot and in Eisenmenger syndrome. After load should be maintained with phenylephrine to reduce shunting. Caution should be executed when titrating oxytocin. Caudal epidural produce less sympathetic blockade. Caesarean section delivery is most safely performed with general anesthetic technique, emphasizing maintaining systemic vascular resistance and avoiding tachycardia. In patient with left to right shunt, this patient are this category with something like atrial septal defect or ventricular septal defect. This shunting increases in either systemic or pulmonary vascular resistance, can increase strain on the right ventricle and potentially lead to ventricular failure. This subset of patient is also susceptible to paradoxical air embolism. So if we are giving epidural to this category of patient, usually we should use we shouldn't use air to feel the loss of resistance, but we should use saline instead. To sum up, this is a very important topic. Every patient should manage it individually. Some patients should be recommended not to get pregnant, and every patient should be managed as we said. Thank you.
Okay, thank you, Dr. Ahmed, for this lecture. Actually, there is a lot of diseases, cardiac diseases, that could we face a pregnant woman have any one of them. So we can face any of them. That's why it was a little bit lengthy lecture. Anyway, we open the floor for questions and answers. Any question, please? We have 5 minutes. Please, Dr. Tariq.
Prof. Asmat, there is a question from one of our colleagues to Dr. Ahmed Samir. Based on what criteria will you request or reserve ICU or high dependency replacement?
It is according to the risk classification. As I said, there is risk stratification. I recommend the WHO risk stratification. You will see category 3. I think this category are in need in ICU bed. They mentioned some diseases like patient with impaired left ventricular or like patient with mitral stenosis. Category 3 and 4 in the risk stratification of WHO, this category of patients are in need of ICU bed.
There is another question here. I'm sorry, Dr. Asmat. There's another question here from our colleague, Dr. Abdel Naim Abdel Maboud. I have a primary gravida. In first trimester was admitted with at Gucci as lobar pneumonia. She is Fontan procedure. What is about? She's complaining about vaginal spotting.
She is with morphine. I heard right.
No, Fontan.
Yes. Fontan. Okay. Fontan disease is she is in a need of a tertiary hospital. She also in a need of an anesthetist with an experience with cardiac diseases, because as I said, this patient with Fontan disease, as I said, usually there is no right chamber. This patient, the systemic venous returns goes directly towards the pulmonary artery. So this category of patients need a meticulous fluid management because they depend mainly on the preload, and any decrease in this preload may worsen hair condition. Also, we have two categories of Marfan syndrome. Some patient, the single ventricle is the left or is the right, and according to the contractility of this ventricle, the patient may or she can manage the vaginal delivery, especially the second stage. But if she is going for vaginal delivery, of course, I recommend cardiac vaginal delivery without straining, and it should be very well monitored. And as I said before, it should be in a tertiary hospital with an anesthetist with an experience in cardiac surgery.
Any more questions? 2 minutes.
I don't see any more questions here.
Dr. Tar Alberbar has a comment.
Yeah, he wants to have a comment on the opioid-based anesthesia.
Yeah. Okay.
Prof. Tariq? Prof. Tariq Alberbar?
Hear me?
Dr. Tariq Abdelbar.
Yeah, we do. Yeah.
Okay.
Yeah, would you like to have a comment before we shift to the next session?
Yes, because this was just mentioned, opioid-based anesthesia, and I don't know if many of the junior colleagues have ever met this kind of anesthesia. It simply means that it's a total opioid anesthesia, and this dated since 1969 when first open heart surgery done under morphine, and since then because of the novels of the new analgesics like fentanyl, sufentanil, and recently remifentanil, you can use it very safely, and I can give the dosage for those who are interested. at induction, 1 microgram per kilogram, given over 1 minute. And then you run an infusion of 1 microgram per kilogram per minute. And you just turn on the vaporizer at 0.2 Mac. So if you're going to use sevoflurane, you just put the dial on 0.4% and tighten. This is very safe on the uterus, so there will be no chance for any extra bleeding from the uterus or gravid uterus. And once this opioid is switched off, 2-3 minutes, the patient is fully awake. This is what I want to clarify for those who probably not knowing what's opioid-based anesthesia is. Thank you.
Any more questions, please? Any questions? Okay. So we're going now to the third lecture.
There is another question about intrathecal opioid for vaginal delivery.
Our colleague, Assistant Professor of Anesthesia. Yes? Okay, please. Let's make it the last one, please. Okay, you can go on.
What about
Yes.
the intrathecal opioid only for vaginal delivery? I think is not applicable, that question.
No. It is written. We may give only 25 mic fentanyl intrathecally. It may be given without local anesthetic. It may decrease the pain. It is written like that. That's right. It may be used.
Okay.
Thank you.
Not at all.
Thank you very much, Dr. Ahmed Samir, for your
Thank you.
lecture. It deserves more time, of course, but we are short of a time. It was very informative, and I think the part you tell about Marfan syndrome would be a good preparation for our interactive session. Now we'll shift to Dr. May Ahmed Ali, Assistant Professor of Anesthesia, Surgical Intensive Care and Pain Management, Qasr Al Aini Hospital, Cairo University. She's going to give us another preparation for our interactive session. Her lecture is very interesting, which is cardiac arrest during cesarean section and CPR during cesarean section. So, Dr. May, you can start, please.
Thank you, Dr. Asmat. Good evening. Dear professors, Dr. Mohammed Abdel-Raouf, my dearest Dr. Ines Kamel, Dr. Magid Salah, Dr. Tariq Abdel-Bar, Dr. Nisreen, all esteemed bouquet of experts. I'm honored to be among you today. I'm going to talk about a very tragic, sad scenario that can happen in people who are supposed to be expecting a happy event. But when this accident happens, it becomes very tragic. It's a simple, short lecture, but I think it's very relevant and very useful. As Dr. Asmat was introducing me, I just noticed that I have written my title as an assistant lecturer. I will change it. So I'll start by the objectives of my lecture. These would be to understand the treatment or management of a pregnant patient, with cardiac arrest, to know the differential diagnosis of this collapsed pregnant patient and understand and appreciate the need of early expert help in this clinical scenario, and to know the modification to the standard advanced life support. Maybe most of you know this chain of survival. I like to introduce it in every lecture about CPR, cardiopulmonary resuscitation, because it emphasizes the importance of the four pillars of cardiopulmonary resuscitation, each of which is totally dependent on the other. I mean that the four rings of this chain have to be intact and connected, because breaking any of these rings will disrupt cardiopulmonary resuscitation and will fail to save the patient. The chain of survival starts with early recognition of cardiac arrest and calling for help in an attempt to prevent it or rescue it early. Then to buy time by starting early cardiopulmonary resuscitation until advanced life support team or the Code Blue team arrives with the defibrillator, which is a very crucial step when managing a resting patient in an attempt to restart this heart and regain spontaneous circulation. When we arrive to the return of spontaneous resuscitation, we have to continue taking care of the patient in what is known as the post-resuscitation care in order to guarantee a good quality of life following this sad event, to minimize morbidity. So let's see what are the causes of cardiac arrest in the pregnant patient. Pregnant patients are similar to normal females of the same age group. They can arrest due to anaphylaxis, due to trauma, due to a drug overdose, whether iatrogenic by doctors or due to drug abuse or due to comorbidities during the pregnancy. What other causes that are specific to the pregnant patient include cardiac diseases, pulmonary embolism, psychiatric diseases, hypertensive disorders of pregnancy, sepsis, hemorrhage, amniotic fluid embolism, and ectopic pregnancy. So to prevent cardiac arrest in the pregnant patient, we should all acknowledge the importance of the left lateral position when handling a critically ill or a peri-arrest patient. We should put the patient in what is known as the left lateral position, or at least use our hands simply to manually displace the uterus to the left. We should always have a supplemental oxygen at hand and use it guided by the oxygen saturation. Whenever we find hypotension or suspecting hypovolemia, a fluid bolus would be a good choice to restore circulation. We should also remember to call for early expert help, the obstetricians and the neonatologists. We want to take care of the two souls inside each other. We should reevaluate our need to use drugs, whether for resuscitation or for the comorbidities, and identify and treat the underlying cause of arrest. So if the patient sadly arrests, there are a few modifications for the management of the basic life support and advanced life support of the pregnant patient. Let's take a look on the basic life support algorithm. This is according to the European Society of Resuscitation. Whenever the patient becomes unresponsive, we should first of all call for non-specific help, confirm cardiac arrests, and then start chest compression in a ratio of 30:2 and continue cycles of 30 chest compressions to 2 breaths, whether mouth-to-mouth rescue breaths, mouth-to-mouth breathing, or bagging, manual bag valve mask ventilation, until the defibrillator or the automated external defibrillator arrives. When we attach the monitor or the defibrillator, we start what is known as the advanced life support, and as all other patients, we will classify the patient as an arrest patient with a shockable rhythm or a non-shockable rhythm, and management will depend on the type. Shockable rhythms include the VF and the pulseless VTAC. They are treated mainly with shock followed by uninterrupted 2 minutes of chest compressions. Cycles continue until return of spontaneous circulation. If the patient arrests with a non-shockable rhythm, such as the pulseless electrical activity or asystole, then we resume chest compressions 30-2 with adrenaline 1 milligram bolus given every other cycle until the return of spontaneous circulation. During the 2 minutes of chest compressions, the team leader and timekeeper should think about the reversible causes that made this patient arrest. Let's remind ourselves with them simply. They are hypoxia, hypovolemia, hypothermia, hypo and hyperkalemia, and sometimes hypoglycemia. Tension in the thorax, pericardial tamponade, thromboembolism, whether coronary embolism or pulmonary embolisms, and lastly, toxins, as we mentioned before, whether iatrogenic or due to psychiatric reasons or homicidal. During CPR, we should ensure, of course, high-quality chest compression, which could be challenging in the presence of a gravid uterus and enlarged breasts. We should take care of the rate, depth, and recoil, use supplemental oxygen, secure the airway. Of course, all of us are experts in the advanced airway. We should attain a proper, reliable vascular access, the intraosseous being a first choice after a maximum of 2 minutes or 3 trials of peripheral venous access. We should continue chest compression uninterruptedly. And once the advanced airway is placed, we lose the ratio of 30-2, and chest compressions become asynchronous from mechanical ventilations. Chest compressions will continue in a rate of 100 to 120 per minute, with bagging at a rate of 10 to 12 per minute. Of course, capnography would be very, very useful to assess the quality of chest compression and detect the return of spontaneous circulation and help us evaluate the prognosis for such patients. So there are a little bit of differences for the pregnant patients. Although we will apply the basic principles that I mentioned before to the basic life support and advanced life support, however, we should include the expert help immediately, the obstetricians and the neonatologists, to help us take a decision regarding the mother and the fetus, whether we are going to rescue them both or rescue the mother alone. Remember that after 20 weeks of gestations, the uterus needs to be manually displaced, or if we are on the OR table, we can use a left uterine tilt, something between 15 to 30 degrees, to relieve caval and aortic compression. Even a small amount of tilt may be better than no tilt at all. This can be done by tilting the supine board or the OR table, putting sandbags or firm pillows or a purpose made for this, a wedge made for this purpose. We can even simply use the size of the kneeling rescuer to tilt the torso of the pregnant patient. We should also prepare for the emergency cesarean section. The fetus will need to be delivered if the initial efforts fail. Of course, early intubation, we are all experts in this. We should consider early intubation. These patients are at highest risk of aspiration. They are challenging in intubation. Their airway might be edematous. Their functional residual capacity is very little, so expert help and a failed intubation drill and alternative airway devices should always be available. If we need to use the defibrillator, we will use the standard energy doses, whether monophasic or biphasic. However, some of us would prefer to place the paddles or the adhesive pads in the biaxillary position for more convenience due to the enlarged breast of the pregnant mother. So while going through the basic life support or the cycles of chest compression, we should consider the causes and treat them one by one. Generally, we use the 4 H's and 4 T's approach. Abdominal ultrasound is an indispensable tool when used by a skilled operator to detect the reversible causes. We should evaluate, of course, fetal viability. Whether there is multiple pregnancy or not, the placenta, whether it's a previa, accreta, whatever. All of these general principles should not delay treatment. The first and most common cause of hemorrhage, which can occur both antenatally and postnatally. Causes include ectopic pregnancy, placental abruption, placental previa, uterine rupture. Of course, treatment is based on an ABCDE approach, fluid resuscitation using a rapid transfusion system and cell salvage. We can use crystalloids and colloids as well. Activate the massive hemorrhage protocol and tranexamic acid, correct coagulopathy, correct uterine atony using oxytocin, ergometrin, or even prostaglandins. The obstetricians may even use uterine compression sutures or intrauterine balloon devices to compress the bleeding surface inside the uterus. You can even resort to radiological embolization of a bleeding vessel and surgical controls through aortic cross-clamping, compression, or even sometimes, tragically, hysterectomy. Drugs which may cause a pregnant patient to arrest include eclampsia, drugs used to treat eclampsia, by which we mean magnesium sulfate. It can endanger the patient's life, especially if she becomes oliguric, and this is best treated with calcium. Central neural blockade that we use can result in sympathetic blockade and subsequent severe hypotension, bradycardia, or sometimes the patient may arrest due to local anesthetic toxicity. As Dr. Ahmed Samir mentioned, cardiovascular disease is not common in pregnant patients or not uncommon. Causes of cardiovascular disease may include myocardial infarction, aortic aneurysm or aortic dissection of the aorta or its branches, and of course peripartum cardiomyopathy. So patients with known cardiac disease need to be managed in a special unit, as Dr. Ahmed kindly and elaborately explained. Pregnant women may develop acute coronary syndrome, especially if they have predisposing factors such as obesity, old age, high parity, smoking, diabetes, and pre-existing hypertension, and of course a family history of ischemic heart disease. PCI or reperfusion therapy is the best percutaneous coronary catheterization. It is the reperfusion strategy of choice for the ST segment elevation myocardial infarction during pregnancy. Of course, thrombolysis is a crucial decision to make. It should be considered if urgent PCI is unavailable. And of course, this is the responsibility of a cardiologist, a specialized cardiologist in the set. Eclampsia and preeclampsia can also lead to maternal arrest. We all know that eclampsia is defined as the development of convulsions or unexplained coma during pregnancy or the postpartum period in patients with signs and symptoms of preeclampsia. Magnesium sulfate is one of the very common and useful drugs that can be used to prevent eclampsia, although we should take care that magnesium itself can lead to arrest if the patient becomes oliguric or the magnesium level increases markedly. Amniotic fluid embolism is also a serious complication that usually presents around delivery. It results in an obstructive shock, sudden cardiovascular collapse, breathlessness, cyanosis, arrhythmias, hypotension, and hemorrhage. There is no specific therapy. Treatment will only be supportive, the ABCD approach, and of course, correction of coagulopathy. Pulmonary embolism, the ghost that is always there in the OR whenever critical patients are around. It can present throughout pregnancy. Once we suspect pulmonary embolism, we should start CPR. The use of fibrinolysis, again, should be done with caution, especially if we are going to undergo perimortem cesarean section. If the diagnosis is suspected and maternal cardiac output has not returned, it should be given. Fibrinolysis should be given. So we now move to one of the crucial decisions, the perimortem cesarean section, yes or no. Let's bear in mind that when initial resuscitation attempts fail, delivery of the fetus becomes our last chance to improve the chances of successful resuscitation of both the mother and the fetus. At 30 to 38 weeks of gestation, the baby can survive even more than 5 minutes from the maternal cardiac arrest. So, by delivering the fetus, we relieve caval and aortic compression. We can have good access to the abdominal cavity, and we might rescue the baby as well. However, not in every time. It's not always necessary to. It's not always. It's not always valid to try to save the baby. Remember that the gravid uterus begins to compromise the inferior vena cava and the aorta starting from 20 weeks of gestation, while fetal viability starts from 24 weeks of gestation. So if we put these two pieces of information together, we can take the following decisions. Younger than 20 weeks of gestation, urgent cesarean section is not needed. The fetus doesn't jeopardize the mother's circulation, and he is not viable, and it is not viable. Between 20 to 23 weeks of gestation, we can consider emergent cesarean section to relieve the IVC and the abdominal aorta and target maternal survival only. After 24 weeks of gestations, I don't know, maybe pediatricians would argue about this figure, 24, but this is what is mentioned in the European Resuscitation Council guidelines, that beyond 24 weeks of gestations, emergent cesarean section should be considered in order to save both the mother and the fetus. Any questions? I will terminate my lecture and would be happy to take your questions by the end. So to sum up, the fetus must always be considered when an adverse cardiovascular event occurs in a pregnant female. Fetal survival usually depends on maternal survival. Initial resuscitation efforts should always focus on the pregnant mother. Thank you.
Thank you, Dr. May, for this very informative lecture. And I believe we are all prepared now to our next session, but we will have some questions and answers for 5 minutes.
I have here a question about ketamine mixed with dexmedetomidine to manage seizures. From Dr. Ayman. I don't know about dexmedetomidine for seizures. I know that ketamine is a good choice to manage intractable convulsions, but I have to revise the literature regarding dexmedetomidine. We usually use it as a sedative. I don't know if it is an approved drug for seizures. I can't see any further questions. If anybody has a question, please go on.
Looks like your lecture was very well explained, so we don't have more questions.
Thank you, Professor.
Another 2 minutes. If anyone has any comment, please.
I don't see any question here for Dr. May. Everybody is very happy with the lecture. Many thanks, Dr. May, from Dr. Shireen Rifat, from Dr. Mariam Botros, from Professor Abdul Bar. Thank you, Prof. Tariq. Thank you so much for your compliment. That's actually here a good question, a very good question from Dr. Abdul Ali. Any role of the bedside echo or ultrasound during arrest in women?
Yes, of course. Of course. I mentioned this in my lecture. Bedside echo is an excellent tool anywhere. It's like using a television over your patient. Of course, using a bedside echo, especially the subcostal view and the fast examination, is very informative. You can detect pericardial effusion, you can detect pulmonary embolism, you can detect intra-abdominal breathing, pelvic bleeding, you can assess the IVC and help in the diagnosis of pulmonary embolism. You can assess pulmonary pressure. You can even see, if you're lucky enough and the patient is unlucky enough, you can see a pulmonary embolus. It's an invaluable tool.
And it is a very valuable tool as well for cardiac arrest in general, rather than only in pregnant women. All compliment here for Dr. Mai, from Dr. Sana Helmi, from Dr. Ihab Tariq, from Dr. Timothy from Africa. So everybody is very happy with the lecture. And Dr. Asmat, if you don't mind, I wish we can move to the next lecture, please. Thank you.
Yes. Thank you, Dr. Mai. And again, this is a very preparatory step for our next interactive session. So we'll have now the event we were waiting for. We have an interactive session. It will be shared between Dr. Mai Ahmed herself and also Dr. Alia Helmi Mohammed, Assistant Lecturer of Anesthesia, ICU and Pain Management in Qasr Al Aini Hospital, and Dr. Fahima Al-Sharqawi, Senior Resident of Anesthesia and ICU and Pain Management in Qasr Al Aini Hospital. And I would like to thank the three of them. I would like to thank this team, not only for preparing this very nice interactive lecture, but also for sharing in the anesthesia management of this patient and the good preparation, pre-op, intra-op management, and even post-op. I will leave you now to start your interactive session, and enjoy, write your question down until the end, and I hope you will enjoy this, inshallah. You can start.
Thank you, Dr. Asmat. I'd like to take a moment to thank as well Alia, Fahima, Dr. Yasmin, assistant professor with me, and the rest of our Shireen, Sarah, all the residents that were with us during management of this case. It was a very interesting case. They did a great job, and I can say that we were very synchronized with each other. We had a great teamwork. Although I will leave you to see the result of our excellent teamwork, still it was an excellent job, and I'd like to thank them all very much for this day. Although it is a sad memory for me. Yalla, Fahima, start, please.
Yes, please.
Fahima, open your mic, please.
Okay, doctor.
We can hear you now. Try to stand close to your mic.
Good evening, my colleague.
Good evening.
We need to see your photo, your video. Who's going to speak? Dr. Mai? Dr. Fahima? Dr. Fahima. Okay. She has the right now.
We will present together a case of Marfan syndrome undergoing Caesarean section. It represents an anesthetic challenge. Fahima, are you ready to present the objectives?
Her video is not.
Yeah.
Video
Can you
not
share
working.
the screen, Dr. Mai? Share the screen, please. We need to see the PowerPoint.
I'm sorry, كل ده مش shared.
Okay, yeah.
Take your time. Dr. Fahima, your video is not working.
Can you see the screen?
I don't have camera in my laptop.
Okay.
Can you see the screen now?
Yes, thank you. You can start.
Never mind with Fahima, just go on. I will scroll into the lecture and you will read the slides for the audience, please.
Okay. Objectives, case presentations, clinical features of Marfan syndrome, anesthetic implications, review of literature. Case presentations, 35 years old female, previously diagnosed as Marfan syndrome, medical history on beta blockers for rate control, ophthalmic surgery for lens dislocations, 37 weeks gestation, gravidas 3 para 2, previous 2 Caesarean sections, spinal anesthesia. What do you think? What do we know about Marfan syndrome?
I invite audience to participate, please, in the chat. Or what we all know about Marfan syndrome, whether the clinical features, the pathogenesis, pathology, anything whatsoever.
Every question here in this interactive session, please.
Of course,
it will be for the audience. Yes, please share.
You can share orally if it's more simple. When we say Marfan syndrome, what's the first thing that jumps into our minds? For me, it's a tall individual. I used to think so. Yes, Mustafa said a CT disorder, a tall person, a risk of aortic regurg, mitral regurg. You're completely right. Connective disease, tall, aortic dilatation. Thank you. Aortic regurg, SRAB. Anything else? Aortic aneurysm, lens issue. Thanks, Dr. Baran. Connective tissue, yes, of course, Shaimaa. Okay, so let us introduce to you difficult intubation. Yes, this is one of the nightmares that I was thinking about in the night of the surgery. Hypertension, aortic bicuspids, yes, laxity of the ligaments, cardiac lesions, scoliosis. Mohammed, you're definitely right. High arched palate, yes, Riham. Spontaneous pneumothorax, of course. So difficult intubation, high arched palate, Yasmin. Aortic tear, this is our nightmare. Arachnodactyly, yes. Spider-like fingers or hands. Okay, I think this is about all. Mitral prolapse, Dr. Rhonda. Hello, Dr. Rhonda, nice. It's an honor that you're with us, Dr. Rhonda. Hello. Professor Dr. Rhonda Badawi. So I think, Fahima, this is about all. We can proceed with our slides. Let's see what we traditionally knew about Marfan syndrome.
Okay, our colleague, what is Marfan syndrome? Autosomal dominant condition, a mutation in the fibrillin protein 1 gene on chromosome 15 that encodes the protein fibrillin.
This is a very nice photo I found by accident on the web. The acronym of Marfan. It summarizes or groups the most relevant problems of Marfan to us: mitral valve prolapse, aortic dissection, retinal detachment, fibrillin 1 mutation, arachnodactyly, nearsightedness, and scoliosis.
Clinical features of Marfan syndrome. Affected individuals may present with a triad of features: skeletal abnormalities, ocular manifestations, cardiovascular pathology. Skeletal abnormalities like long, thin extremities, arachnodactyly, scoliosis, ocular manifestations, lens dislocation, retinal detachment, cardiovascular pathology, aortic media weakness, aortic root dilatation, aortic valve incompetence, mitral valvulopathy.
These are some photos of the common lesions.
On the left, thoracolumbar kyphoscoliosis. On the right, foot deformities.
Valgus, foot, deformed foot. On the left side, we can see hyperextensible joints. On the left, on the right side, the oral cavity with slight retrognathia and an arched palate.
Lens dislocation.
What is known as ectopia lentis.
Ectopia lentis.
This is an interesting score system, which was known as the Gent nosology. It was revised in 2010 and introduced 7 new criteria to diagnose Marfan syndrome. Apart from the classic triad that we were explaining, this nice score could simplify how to differentiate or to point out Marfan syndrome among other connective tissue diseases. So just one criterion is sufficient for diagnosing Marfan syndrome. Can you go, Fahima?
In absence of a family history, aortic root Z score equal or more than 2 plus ectopia lentis, or aortic root Z score more than 2 or equal plus fibrin protein 1 mutation, or aortic root Z score more than or equal plus systemic score more than 7 points, ectopia lentis and fibrin protein 1 mutation with known aortic pathology.
This is the Z-score calculator obtained online. As we can see here, the calculator integrates the height of the patient, his weight, his age in years, his body surface area, and then the most important thing is the measurement of the aortic root at the sinus of valsalva sinus in centimeters, and then calculates what is known as the Z-score. So as we can see here, for this particular female patient, she has an aortic root diameter of 3.7 centimeters and her score is 3.05. So if we can apply this score to our patients, you'll probably, of course, we didn't have her measurements, her height and weight, but I guess that it will easily by far pass the two, as we will see later.
In the
presence of family history, the score is much more simpler. Go on, Fahim.
In the presence of a family history, there is one of these 3 is enough for diagnosis of Marfan syndrome, ectopia lentis, or systemic score more than or equal 7, aortic root Z score more or equal 2.
These are the points for the systemic score, which include all musculoskeletal ocular deformities.
Take-home message for anesthesiologists. There are a number of conditions of connective tissue with a similar phenotype that can be confused with Marfan syndrome. Recently published modifications of the diagnostic criteria facilitate the differentiation of Marfan syndrome from these conditions. Focus has shifted from musculoskeletal signs to cardiovascular and ocular abnormalities.
Surprisingly, by the revised score, the presence of a dilated aorta plus ectopia lentis is now considered sufficient to give an equivocal diagnosis of Marfan syndrome.
Back to our case. Immediate termination of pregnancy was recommended. Patient scheduled for urgent cesarean section. Pre-Anaesthetic evaluation. Patient was found to have good functional capacity with no dyspnea, orthopnea, or lower limb edema. Airway assessment was satisfactory. Melampathy class 3. Preoperative echocardiographic examination revealed Marfan syndrome with aortic root aneurysm, 62 millimeter, and severe aortic regurg for surgical consultation.
62 millimeter diameter. Please remember this figure.
So what do you think, what would be the ideal anesthetic plan? Regional versus general anesthesia? What do you think and why?
Invite all of you esteemed guests, audience to participate. Let's vote.
Okay.
Which would go for regional and which would go for general anesthesia for such patient. Sophia went for GA. Why, Sophia? Isra Badr went for regional. Why, please? GA, Burhan, GA, Marwa. GA. Oh my goodness. regional epidural spinal, Shireen, Amgad GA, Sophia aortic dilatation 62, so this is why she wants GA. Combined spinal epidural, thank you, Karim. Thank you very much. You will regional because of risk of difficult intubation, Dr. Rhonda. Of course, Dr. Rhonda, you're an expert of difficult intubation, so I'm sure you will, nobody can compete. GA, regional, special epidural, Mahmoud Salim, Hilal, combined spinal, regional. I think that the regional votes are the intubation. Combined spinal, regional epidural, regional. Combined spinal epidural, Yasmin El-Basha, hello. Actually, both are okay. Very nice political opinion, Dr. Brown. Regional, Masoud Mustafa, Svetlana, combined spinal epidural. Welcome to our team, Svetlana. Mahmoud Abdel Gawad, regional epidural Tariq. El-Husseini Ahmed, GA. 1 GA now. Okay, I think we got our votes. I think that the majority went for epidural or regional. 2 GAs to come. El-Husseini Ahmed, Mahmoud. They adopt the GA policy. Okay, let us tell you what we did. Or let us first tell you who likes or prefers regional anesthesia, what would be the pros and cons, and who prefers general anesthesia, what would be the pros and cons from the literature point of view. Fahima?
Okay, our colleague.
Yeah.
We forward to all what anesthesia give to this patient, and we would revise the advantages and the disadvantages of regional anesthesia. Advantages: avoids airway manipulations, intubation pressure response, avoids barotrauma, low dose combined spinal epidural anesthesia, allows titration of level of anesthesia. Disadvantages: technically difficult scoliosis, corrective surgery, difficult resuscitation, sympathectomy.
It would result in sympathectomy if not controlled with drugs. Of course, regional anesthesia could result in systemic vasodilation, of course, pooling.
General anesthesia advantages: if acute dissection occurs, airway is protected, possible immediate cardiac surgery, inhalation agents may decrease cardiac ejection force and decrease aortic dissection risk. Disadvantages: risk of hypertensive response to intubation, failed intubation due to difficult airway, aspiration risks, cesarean section plus general anesthesia equal high risk for awareness, hyperdynamic cardiovascular responses, barotrauma, cystic lung due to some patients with cystic lung.
Elastic weakness and cystic lung degenerations.
Back to our case. Combined spinal and epidural anesthesia was chosen as Plan A for anesthesia. 2 wide peripheral cannula were inserted plus a stosor gauge cannula in external jugular vein, arterial cannulation of left radial artery, basic monitors were attached ECG, non-invasive blood pressure, pulse oximeter, heart rate, 80, arterial blood pressure 124 over 60 millimeter, oxygen saturation 99%.
On room air.
500 millicrystalline solution was administered colloid. Epidural catheter was successfully inserted at L2 and L3 space. Total volume of 2.5 milli, 2 milli hyperbaric bupivacaine plus 25 millimeter fentanyl for the subarachnoid block. Spinal anesthesia failed to achieve adequate block.
Everything was very smooth, but effectively spinal anesthesia didn't achieve adequate block.
Loading dose of isobaric bupivacaine 0.5%, 15 milli plus lidocaine 2%, 5 milli were given in the epidural catheter. However, epidural anesthesia was unsuccessful as well.
Very sad.
So what do you think? Why did regional anesthesia fail?
Again, those who are advocating regional anesthesia, could you share with us what's your opinion, what went wrong? Our audience, please share with us what went wrong.
Yes, scoliosis.
Karina, there was scoliosis. I can't remember if she was scoliotic or not, but the technique, the steps of the spinal were very smooth. We could receive CSF smoothly. Epidural loss of resistance was very well appreciated during epidural anesthesia. The catheter was introduced smoothly. Drug injection was smooth. No, it was not difficult due to deformities. Everything went smoothly. مش كده فاهمة؟ They said they said it was very, very smooth. Nothing. Yes, total fail.
Total fail, yes.
Yes, total fail. Trabeculation maybe, low level. Risks of spontaneous pneumothorax, epidural space not totally connected as part of the syndrome. Maybe, I don't know. Abnormal anatomy, we can't guarantee, except with MRI. Dr. Nisreen Rifai, of course. Dural ectasia, thank you, Safia. Dural ectasia, Dr. Tariq, of course. Thank you, dearest Professor, Dr. Tariq Abdelbar. Resistance to local anesthetic, it's not actually a resistance. You will see it's ineffectiveness resistance. Yeah, we will see on the next slide why did this regional anesthetic techniques fail. Although we have very skilled teams, we used isobaric, we used hyperbaric for the spinal and isobaric for the epidural, yes. Dr. Burhan, we used the standard hyperbaric with fentanyl, 2.5 milliliters total, hyperbaric for fentanyl, and 1020 isobaric for epidural. Yes, of course, Dr. Randa, connected tissue adds to the difficulty to find the space, but we found the space and we injected with no problems, but we got no block. Sometimes there is problem with the drugs. I don't think so. On that day, the drugs worked well with other. Of course, I agree, especially in Egypt, we have bad storage conditions, but no, for this day, everything was well with the drugs. Yes, she had a previous successful subarachnoid. What do you mean, Mahmoud? We are experts. Yasmin, septations within epidural space, maybe. Is it ectasia? We don't have an MRI available. Epidural septal, Dr. Randa, maybe Dr. Randa. We don't have epidural and we didn't use ultrasound. I think we should learn how to use ultrasound to detect the epidural space and visualize it. I still have to learn this. Supradural, we can't tell, maybe. But the subarachnoid as well didn't work. Tall patient, she is tall, but we should have some degree of block. We didn't have any block. Maybe a little tingling in her toes or her up to her ankle, something like this, but no solid, robust block. No. A tall patient would supposed to have something like a saddle, something like a level of مثلا L8, L10 block, but this didn't happen in this patient. Okay, so let's see what went wrong. Now we will introduce Dr. Aliet to discuss with us the dural ectasia. This was something new to me. I didn't know what was meant by dural ectasia. I read it the night before surgery, but I said we have to take our chance. Yeah, Dr. Aliet.
Hello,
Okay,
everybody.
video tag, sorry.
there is something called dural ectasia. Up to 50% of the spinal anesthetic given to morphine women are inadequate, even when larger than average local anesthetic doses are used. Weakened elastin elements within the connective tissue promote expansion of the lumbosacral dural sac. An enlarged volume of CSF is proposed to be the main causative factor in failed spinal anesthesia in Marfan syndrome. Increased CSF volume reduce block height and cause faster two-segment regression time. The postulated mechanism are dilution and sequestration of local anesthetic into ectatic cyst, cephalid drug spread. The image show 3 grades of dural ectasia, grade 1 mild and moderate and severe grade 3. There's a case report published in International Journal of Obstetric Anesthesia 2080, titled as Successful Spinal Anesthesia for Caesarean Section in Patient with Marfan Syndrome Complicated by Dural Ectasia. It described 17 years old female with Marfan syndrome with her second pregnancy, admitted for elective section at 37 weeks gestation. She has 44 millimeter aortic root dilatation and borderline mitral valve prolapse. The author postulated that inconsistent intrathecal distribution might be overcome by application of warmed isobaric provocaine in a seated patient, injected as far as possible away from diluting effect of ectatic dural sac. The image on the right.
Okay, Alia, go on.
The image on the right side show T2 sagittal MRI of patient lumbosacral spine with dural ectasia and bony scalloping small black arrows and conus medullaris indicated by large white arrow at the T12 L1 level.
So here they visualize the vertebral column and spinal cord, located the conus medullaris, the end of the spinal cord or the conus medullaris, as we can see with the white arrow. They also found the dural ectasia. It's still in the early phases. There's only some bending in the posterior border of the vertebral bodies. So they postulated that if they can put or use isobaric bupivacaine as far as possible from the ectatic dural sac and keep the patient seated for some time, they might succeed.
2 milliliter isobaric 0.5% provocaine plus routine opioid to a total volume, warmed at 37 degrees Celsius immediately prior to injection at the level of L1, L2 interspace. Bilateral sensory block T4 was confirmed at 5 minutes post-intrathecal injection.
To the right, we can see the apparatus that they invented or they used. They used a 500 milliliter bag of saline wrapped in some. They heated the bag and wrapped and connected an IV line, which was wrapped around the syringe and infused the warm saline around the syringe to keep it warm during injection.
In conclusion to this case report, a warmed injected of hypobaric provocaine, fentanyl, and morphine administered with the patient in seated position and the maintenance of that position for 5 minutes post-injection produced a functional neuroaxial block.
By the way, we kept our patient sitting for some time, but it didn't work. Fahima?
Back to our case. Induction of general anesthesia plan B was conducted with 2 mg midazolam, 150 mg propofol, 50 mg atrachlorium, smooth tracheal intubation of 7 mm cuffed intratracheal tube. Anesthesia was maintained by sevoflurane in 50% oxygen. Patient was intubated uneventfully, hemodynamically stable, heart rate 75 arterial blood pressure 100/60 millimeter, oxygen saturation 99%. A viable healthy newborn was delivered. Then naloxone 7 milligram was given. Estimated blood loss around 700 millimeters. At the end of surgery, the patient was fully reversed from muscle relaxation. Patient recovered fully conscious, hemodynamically stable, heart rate 77, arterial blood pressure 110/70, pain-free.
And through the operation, her blood pressure remained in this range, maybe a little lower, I think due to the effect of the regional somehow. And we used small titrated shots of ephedrine to keep it around 110 or 120/70. She was never hypertensive or tachycardic, not before surgery, not before intubation, not during intubation, and not even after extubation.
A patient was transferred to PACU. 10 minutes later, patient became pale, hypotensive, blood pressure around 70/40, and confused. Colloid resuscitations and 30 milligram ephedrine failed to improve arterial blood pressure. Immediate transfer to the operation room. Patient became pulseless and unresponsiveness. Cardiopulmonary resuscitation started. Endotracheal tube inserted. Defibrillator attached. Asystole. 2-minute chest compressions with adrenaline 1 milligram, alternating every other cycle 3 to 5 minutes. Post-arrest CBC was done. Hemoglobin 8 gram per deciliter. Serial EPGs, severe metabolic acidosis, normal capillary blood glucose. Transthoracic echo was used to exclude reversible causes of cardiac arrest. The 4 H's and the 4 T's that Dr. May mentioned in her lecture. Was excluded.
We used the abdominal probe of the echo machine, and this was the only probe available. We could look at the anterior quadrants, the 4 anterior quadrants of the lungs, looking for tension pneumothorax. However, on the left side, by the 2D mode, there were the A lines and a few B lines. Maybe you can't see them here, but we can see them in the video. So by the 2D mode, by the M mode, we illustrated the seashore sign. And as you can see here, the pleural line, the bright line in the middle of the screen is moving. It's sometimes called the ant line. There are a few laser-like hyperechoic lines extending from this line to the end of the screen, which means that the pleura is sliding. There is no air between the two pleural layers. So tension pneumothorax is excluded. However, we performed fast examination to exclude, together with the obstetricians, the intra-abdominal and pelvic bleeding. So as we can see in the right upper quadrant, in the Morrison pouch, there were no fluid collection, whether perihepatic or perinephric. In the left upper quadrant as well, perisplenic and perinephric, there were no fluid collection. In the abdomen, it was okay. In the pelvis, it was okay. However, surprisingly or sadly, in the subcostal cardiac view, we could see a hypoechoic shadow encircling the heart, suggesting pericardial effusion.
Ultrasound cardiosynthesis was done, and aspiration of 170.
By the cardiothoracic, sorry, Fahima, ultrasound pericardiosynthesis was done by the cardiothoracic. I don't remember he was the resident or the assistant lecturer, but he came and confirmed pericardial fluid collection with us and inserted 20 cc's syringe and started aspirating a total of 170 milliliters of blood. Fahima?
3 bagged RBCs plus calcium chloride were administered. Cardiopulmonary resuscitation continued for 60 minutes with no return of spontaneous circulation. So, what do you think the pathology of this condition?
Would some of our esteemed audience share their experience or of what went wrong? Or how did this patient dissect? Yes. Dr. Randa, I can see you mentioning that tracheum was not a good choice. I totally agree, but rocuronium is not always available in the theater. There are very limited supply. Of course, we should have asked for it, but intubation went well. There was no problem with the intubation. Yes, she dissected. The question, why? This is what we will see now. Maybe sudden relief of the gravid uterus. This is what any sensible person would think, yeah. But lots of gossip were going around. It must have been because of the anesthesia. She must have coughed. She must have strained. Blah blah blah. Nothing of this really happened. The patient had a very smooth recovery. She was awake. She was pain-free in the recovery room. She was talking with us. 72, it was 62, I think, or 63 aortic root. Dr. Mustafa is indication for intervention in Marfan. It be accepted for other cases. You're totally right. This is what we will see. This is what all literature agreed upon. Does anyone else have any point of view regarding this case? Sorry.
Alia.
Okay, we can introduce Dr. Alia again to search literature with us. Did they use methergine?
No.
No, they didn't use methergine. Pabel. It should be done in cardiothoracic OR. You're completely right, Dr. Nesreen. I don't know if this is feasible or not. I didn't think of this before. Yeah. I think Mustafa. I think preoperative EVAR may be a choice. Okay, let's search literature and find out the core issue for this patient. Dr. Alia.
Hello back. A paper published in Journal of American College of Cardiology 2021 titled Pregnancy-Related Aortic Complication in Women with Marfan Syndrome. A single center experience of 169 Marfan Syndrome women. It concludes that pregnancy-related type A dissection only occurred in patients unaware of their diagnosis. Type B dissection remain unpredictable complication.
Of course, you all must know that the aortic dissection type A is the one that involves the aortic root or the ascending aorta, and type B is the one that includes the abdominal aorta, which is less serious.
Also, a paper published in American Heart Association 2016 titled Aortic Complication Associated with Pregnancy in Marfan Syndrome, the NHLBI National Registry of Genetically Triggered Thoracic Aortic Aneurysm and Cardiovascular Condition, stated that pregnancy in women with Marfan Syndrome is associated with an 8-fold increased aortic dissection risk, both type A and B, particularly in postpartum period. Cardiac checkup with echocardiographic assessment of the aortic root and ascending aorta before planned pregnancy or during unplanned pregnancy is recommended. The European Society of Cardiology has a paper published titled Cardiovascular Disease.
Practice guidelines. Sorry, Ali. These are the clinical practice guidelines 2010 of the European Society of Echocardiography of cardiology, stratifying the maternal risk of mortality and morbidity with cardiovascular disease during pregnancy. You can see here the Marfan with aorta more than 45 millimeter diameter stands as an independent risk of high mortality and severe morbidity in this patient population.
in 2030 Journal of Anesthesia Analgesia, a paper titled Marfan Syndrome During Pregnancy, Anesthetic Management of Delivery in 16 Consecutive Patients. This is a retrospective medical record review focusing on the anesthetic management of delivery of all parturient with Marfan syndrome, followed at Bechet Hospital, the French referral center for all Marfan syndrome patients over a 6-year period. Pregnancy may accelerate aortic root dilatation, connective tissue weakness, and increased aortic stress due to increased cardiac output. Pregnancy-induced increased cardiac output reach a maximum immediately after delivery. Labor pain, autotransfusion secondary to uterine contraction. Pregnancy and delivery expose patients with Marfan syndrome to increased risk of life-threatening dissection, especially when the aortic root diameter is more than 40 millimeters. Beta blocker therapy is the cornerstone of Marfan syndrome management. In non-pregnant patients, beta blocker therapy has been demonstrated to slow the growth of the aortic root, significantly reduce the incidence of aortic regurgitation and aortic dissection, cardiovascular surgery, and congestive heart failure and death. Current guidelines suggest that beta blocker therapy should be instituted at the beginning of the pregnancy if the patient is not already taking this therapy, maintained throughout pregnancy. If the female present preconception, a history of aortic root dissection or aortic valve replacement with mechanic prosthesis or aortic root diameter more than 45 millimeter, we should advise her against pregnancy. But if aortic root diameter is 40 up to 45 millimeter, case-by-case basis recommendation against pregnancy.
I'd like to attract attention that this patient presented to the OB/GYN department at 37 weeks of gestation. They hadn't done any antenatal care for her. She came in her late pregnancy asking to deliver her baby in the Qasr Al Aini hospital and acknowledging the risk.
Post-conception. If aortic root diameter is more than 45 millimeter, terminate pregnancy. Beta blocker therapy should be titrated to reduce resting heart rate by more than or equal 20% and to continue intrapartum. Echocardiography at the beginning of the pregnancy and at the end of the first and second trimester, and each month during the third trimester. Mode of delivery should be decided at a multidisciplinary meeting of obstetrician, cardiologist, and anesthesiologist. The decision is based on patient history, reference, and fetal growth and progression of aortic root diameter, repeated echo exam. Vaginal delivery is allowed if aortic root is less than 40 millimeter or 40 millimeter up to 45 millimeter with epidural catheter. Limit the second stage expulsive effort. Indication of elective cesarean section, aortic root diameter more than 45 millimeter, progressive increase of aortic root diameter, history of aortic repair for barrel dissection, severe fetal growth retardation or maternal preference. If emergent cesarean section due to aortic root diameter more than 45 millimeter or developing aortic dissection should be followed by immediate aortic repair in the same setting. Recommendation, maintenance of hemodynamic control during anesthesia for CS is way more important than the anesthesia technique itself. There is no evidence that one anesthetic technique is better than another. General anesthesia with opioid or titrated combined spinal epidural.
This is the site for, especially for the anesthesia or the orphan anesthesia, or an online site for that offers recommendations for anesthesia of patients with Marfan syndrome. They recommended necessary additional diagnostic procedures preoperatively. اتفضلي عليها.
Echocardiography or cardiac MRI, significant dilatation of aortic root should be referred to cardiothoracic surgeon for evaluation of aortic root replacement prior to elective surgery. ECG if show left ventricle dilatation may predispose to alternation of repolarization and fatal ventricular arrhythmia. Aortic root diameter more than 4 cm measured at valsalva sinus level or history of aortic dissection should deliver in a center where cardiovascular surgery is available. The 2010 American Colleague of Cardiology and the American Heart Association and the American Association for Thoracic Surgery guidelines recommend elective operation for Marfan syndrome patient at an external diameter of more than or equal 5 cm to avoid acute dissection or rupture. Indication for repair at an external diameter less than 5 cm, rapid growth more than 5 millimeter per year, family history of aortic dissection at a diameter less than 5 cm, or presence of progressive aortic regurg. Prophylaxis against infective endocarditis is not required unless there is a mechanical valve. Chest X-ray should be ordered preoperatively. History of spontaneous pneumothorax. Patients with severe scoliosis should undergo pulmonary function test to evaluate the extent of restrictive lung disease. A particular preparation for airway management, they anticipated to have a high arched palate with crowded teeth, may make visualization of the larynx during direct laryngoscopy difficult. Clinically symptomatic cases of atlantoaxial dislocation in this patient are rarely reported in literature, and screening radiograph of cervical spine for patients with Marfan syndrome undergoing general anesthesia are not routinely recommended. Patients at increased risk of developing pneumothorax, which should be kept in mind during positive pressure ventilation. Excessive traction of laryngoscopy should be avoided to prevent temporomandibular joint dislocation. Cardiovascular response during laryngoscopy should be blunted pharmacologically. Any question?
So our take-home message, Ali, we will keep questions to the end of the lecture.
Okay. The presence of dilated aorta plus ectopia lentis is now sufficient to give an equivocal diagnosis of Marfan syndrome. Beta blocker therapy is the cornerstone of Marfan syndrome management. Pregnancy with Marfan syndrome is associated with 8-fold increase in risk of aortic dissection, type A or type B, particularly in postpartum period. Mode of delivery should be decided at a multidisciplinary meeting. Maintenance of hemodynamic control during anesthesia of CS is more important than the anesthesia technique itself. There is no evidence that one anesthetic technique is better than another. General anesthesia with opioid or titrated combined spinal epidural. Elective operation for Marfan syndrome patient at an external aortic diameter of more than or equal 5 cm to avoid acute dissection or rupture.
Thank you very much.
Thank you very much, Dr. May and Dr. Alia and Dr. Fahima. And thank you again for the management and for the interactive session. And we are having now 5 minutes, or we can make it even 7 minutes. Yeah, for questions, please.
Thank you, Dr. Sana, for your praising. Thank you very much. I agree with you that using ultrasonography was very, very helpful. Muhammad Magdi Gaber was asking, why didn't we give opioids in the induction to decrease pressure response, and it could make difference to decrease incidence of dissection? Well, as we all know, our concern during pregnancy, during cesarean section, is the depression, respiratory depression of the fetus. So we usually reserve opioids until delivery of the fetus, and this is what we did. During induction, the patient was already on beta blockers, and she was in tachycardic. We used dormican or midazolam together with 150 milliliters of propofol. Dr. Asmat pointed out when we were revising the session that the patient might have benefited from xylocaine. I totally agree. However, luckily, intubation wasn't stressful, and her blood pressure remained on the hypotensive side during surgery. Is the key point in this challenging case that I personally didn't recognize because I hadn't have enough time to prepare, and this is an important point that we want to discuss with the obstetricians, that such serious cases should be handed to us at least 1 week before operation. You can't just introduce such case at 5 p.m. for me and expect me to know everything about it in just 3 to 4 hours. So if we conclude from this session that whenever we have a Marfan syndrome undergoing any surgery whatsoever, we should look at his aortic root diameter, and that the aortic root diameter in this patient is huge. The wall is very, very thin. As I was telling my colleagues, if this patient sneezed while she was walking, she might have died. So as Yasmin mentioned, maybe only the involutional changes of the uterus would have increased the shear forces over the aorta. Of course, intubation, pressure response of intubation and extubation must contribute. And this is why I chose, together with my colleague, to give her a combined spinal epidural, because I was very aware of the pressure response and I wanted to avert it by any means. I didn't, I hope that it would work, and as the previous 2 spinal anesthesia that she had, but obviously her elastine was going very, very weak by age because her aorta is huge. Of course, she has no antepartum records of progression of aortic root dilatation, which is another challenge. So I think this is the key point. If we had all, and very ironically, that the cardiologists and the cardiothoracics who saw this patient before surgery, none of them pointed out that we should repair the aortic root or perform it in the cardiothoracic department or anything like this. So this is, I think, this is the key point.
May I have a
comment? Actually, yes.
Okay.
I will just give a comment, Dr. Saad.
Okay,
actually, the team didn't find a time really to arrange if she can deliver in the cardiothoracic surgery section. So after delivery of the baby, immediate aortoplasty would be done for her, because she presented maybe less than 1 day only before the surgery. And the decision by the cardiologist was to terminate pregnancy immediately. Why she took 2 spinal before and it was working with her? Maybe the ectasia and other things and the elastine was not that damaged as the last pregnancy and last cesarean section, because her condition is progressive. Again, when she took these 2 spinal and 2 cesarean deliveries before, maybe again the aortic dilatation was not that huge. So the thing, or the take-home message, as Dr. May said, and Dr. Nesreen shared also, if we have a time for next patient with this grave pathology, we maybe the best thing is really to arrange her to deliver in a cardiothoracic theater with all the surgeons and all the equipment available to take her immediately after delivery of the baby and closure of the uterus and ending cesarean to make for her the correct aortoplasty. Okay, you can go.
An interesting question in the chat box here from Dr. Muhammad Mustafa. Is beta blocker going to increase aortic regurgitation? Although it might increase the regurgitant fraction, but definitely decreasing the heart rate and the force of contraction will decrease the shear forces, the friction of the blood flow and the turbulence of the blood flow with the walls of the aorta, which is far more important. If you increase the volume of fluid inside the container slowly, you wouldn't expect it to rupture. But if there is a lot of turbulence and shear forces in a weak wall, of course it will crack. Yasmin Al-Basha, Dr. Yasmin Basha, for the future, would you recommend this case to be done in the cardiothoracic theater? Of course, we should ask and arrange if this is possible or not. If they would repair such case or not, we should prioritize. Are we going to rescue the mother? And I mean, if we are going to target to repair the aorta and move to a heart-lung machine and compromise the fetal circulation before extracting the baby in order not to involute the uterus, or to extract the baby and just decide that this is a mortality case, something that the multidisciplinary team should discuss together with the patient. Of course, the patient knew that she was a mortality case, and they were sadly very accepting this before surgery. But we have to move forward to multidisciplinary care of patients. This is very important.
Can I ask you something, Dr. Mai, or all of our colleagues also, they can share? What do we think the most leading factor for the dissection of the aorta and the following cardiac tamponade? What do you think? Because we ask if she sneezes, if she coughs, if there is pain in the post-operative period, if any increase in the blood pressure or any change in the vital signs during intubation, extubation, and there was nothing of all that. So what do you think happened in the PACU? Let's make a brainstorming led to the dissection of the aorta. Anyone can share, even in writing. What do you think, Dr. Nesreen?
Sorry, can you repeat the question, please?
Yeah, I mean,
I was
now,
preparing
you said the patient came to the PACU, our post-anesthetic care unit. She was calm, awake, fully awake, pain-free, and vitally stable. She did not cough or sneeze. She was completely stable. And 10 minutes later, she developed the full dissection of the aortic valve with the cardiac tamponade. So, like a brainstorming, what do you think has happened to lead to that?
I think it was mainly the evolution of uterus, which pushes up to 30% of the circulation back to the heart. So it increases the preload.
Yes, I think this is my opinion too, because thanks to our anesthesia team, that the anesthetic management pre and post and even after the event and intraoperative, it was excellent. They used all the available tools. Immediate ultrasound and echo was done for her using the curved probe of the ultrasound machine of the OB-GYN theater. Cardiocentesis was done. Everything was okay. But as we said, it's a very, very risky patient that should not even, if she had any antenatal care, she would be advised not to have a pregnancy for the third time. So I think it's...
sorry, Dr. Tahir Abdelbar likes to comment. Please do.
Yes, please.
You mentioned that you castrized or you inserted a cannula into the radial artery, right?
Yes.
You hear me?
Yes, Doctor.
Yeah.
Okay. The radial artery was cannulated, right?
Yes.
Was it attached to the monitor to monitor B2B?
No, it wasn't. Because I'll tell you why, Dr. Tariq, frankly. We cannulated the radial artery يعني in the middle of the, يعني after induction and intubation and inserting the external jugular. And as you know, sir, these the domes and the cables, it's very difficult to take them out and obtain them. So by the time we were يعني starting to prepare the invasive arterial monitoring, we were ending surgery. It was a very uneventful surgery. It took something like 1.5 hours. So we didn't manage to get it connected. I personally went into the room several times and I found her okay, so I didn't bother to ask to put to connect the transducer. I can't remember if this room has a compatible cable or not, because not all rooms have it.
Non-invasive blood pressure monitor, your Dynamap was measuring every 3 or 5 minutes.
5.
I mean, it was stable. Yeah.
Yes, doctor. Yes, during the regional anesthesia, almost first.
Continuously monitoring the patient. Yeah.
Every few minutes. Once it failed to attain a sensory level and we moved to general anesthesia, to switch to every 5 minutes. So the patient has a stable heart rate, a stable blood pressure, blood loss was.
I think, Dr. May and Mr. Dr. Tar, I really think if there is, you have a good point, of course. Because the invasive arterial blood pressure measurement will give you a second-to-second changes. But I think if we had a grave change that would let us suspect that this was the cause of the aortic dissection, it will not stay like for 1 or 2 minutes, because the frequent reading of the Dynamap also give us a continuous monitor that she was in a stable vital signs or a very, very minimal vibrations up and down from the baseline readings. So I think this was not the cause, or even if like that, it could maybe happen intraoperatively. But what happened was post-operative, and like 10 to 15 minutes. Yeah, I mean, if she was already awake, extubated, and then go to the PACU, this will take like transferring the patient from the OR table to her bed and moving to the PACU. This would take 10 minutes. And then after 10 more minutes from arriving to the PACU, the event happens. So this is actually 20 minutes after extubating the patient, at least 20 minutes. So this means that the event or what had happened in the post-op, not in the intra-op.
Can I give a comment, please?
Yes, please.
Okay. Reading the blood pressure every 5 minutes, these are missed at least 350 readings. Okay? And what I want to say in this critically ill patients, monitoring of the blood pressure invasively, you have a B2B reading in front of you. Number 2, what I can make to reduce the pressure response to extubation is just after the closure of the peritoneum. Now the lady this is a surface surgery after. So I can extubate, I can get out the endotracheal tube and insert a laryngeal mask airway. So the awakening will be much smoother than the awakening from an inserted endotracheal tube. Number 3, I have to keep an eye on the blood pressure throughout the patient's stay, either in the OR or in the recovery, and while transferring the patient from the recovery to the intensive care unit. Because this is not a case that's to be left with the nurse or left unattended. So
Ironically, we were all around her in the recovery room. Me, Dr. Yasmin, the second assistant professor of the day, Dr. Nashwa Zayed, Dr. Marianne, and I think one or two residents. We were all in the recovery room around the patient, and she was talking to us. Suddenly, while we were standing like this, I started to notice that she has become confused. She started talking.
By the way, I'm not accusing.
I'm just being emotional about this case.
To make the outcome
yes.
better in the future cases. This
is totally yes, excellent.
Only my
of course, Dr. Tariq.
If sneezing, probably the patient sneezed or coughed, or I mean, it can happen from secretions in her larynx. I mean,
so I'm using sneezing as a figure of speech. I mean that she has a very, very, very thin aorta, so that if anything just tickles this wall, it will rupture. We should have acknowledged this, all of us.
I'm sure that this happened. I mean, after her transfer to the recovery. That's sure. Because the rupture is just instantaneous. That's but how to improve the outcome is just to keep an eye on keeping her blood pressure. I mean, on the low normal. I mean, her blood pressure should not exceed 95 millimeter of mercury systolic, and the mean pressure of 65, 70 maximum. That's perfect for her. And this can only be achieved by a beat-to-beat monitoring of her blood pressure.
I totally agree with you, sir.
Totally agree with you, Dr. Tariq. Of course, this is take-home messages. Yes.
She should have a monitor for reversible anesthesia.
So probably with the we can discuss these things and. In the OR, as regards to the domes, everything related to the arterial line. So,
Dr. Tariq, the laryngeal masks. We have a tragedy with the laryngeal masks.
Anyway, I mean, if you extubated the patient, I can comment on that one, which is, I think, your second point, Dr. Tariq, about removing the tube earlier and continue with the LMA. I think the risk of extubation is there anyway. I mean, if she finished surgery or not yet, she will be eventually extubated at the end.
No, extubation when either the patient is under light anesthesia or fully awake is totally different from a patient who is under anesthesia. You can give a shot of 5 mL of propofol prior to extubation. You can give a shot of 50 or even 100 mic of fentanyl before extubation, 3 minutes before extubation, and you can always do this. I mean,
but I will ask you something. Do you trust the laryngeal mask in a potentially, all cesarean section is like a potentially full stomach?
After the delivery,
yeah.
No more. I mean, her uterus. The moment the surgery closes the uterus, it's about 25% of the size at full term. So,
Wallahi, Dr. Tariq, you're very experienced and brave anesthesiologist, but me myself in my practice, I couldn't risk it putting an LMA in cesarean section.
This is elective. The patient has got. I don't know whether she got something antibiotics. The baby is out. The uterus is back to normal or near normal, and it's a surface surgery after the closure of the peritoneum. So she's still under deep anesthesia. I mean, she's fully anesthetized under effects of analgesia. Extubation will not do any harm for her, and reinsertion of the particularly and undermining the particularly that intubation was easy. There was no problem with the intubation. So
Yes.
I mean, even if you are not happy with the laryngeal mask, which I doubt so much, then you can reinsert the endotracheal tube under fully relaxed anesthetized patient.
You know, Dr. Tariq and Dr. May and Dr. Nesreen and all the colleagues, I think what really helped her for smooth intubation and smooth extubation is that she was under beta blockers. This would really have diminished or completely, stopped the pressure responses to intubation and extubation. That was her luck. Really, it's her luck. But anyway, these are valuable comments from all the colleagues, and I think we took 1 hour in this session. Yes, Yama, you have any more comment? Yes, please. Quickly.
Would you recommend using dexmedetomidine as an opioid sparing and anesthetic sparing that would offer her some anxiolysis, some bradycardia during anesthesia or not?
Look, what I usually give in cesarean section, if the patient is doing, I mean, I don't give midazolam. I don't give anything like that. If I want to sedate the patient prior to admission to the OR, I just give a tiny dose of propofol. 30 milligrams of propofol given on her transfer to the OR would do the job of midazolam with no bad effects. Number 2, give her good analgesia. I mean, if you want to give her morphine, why not to give her morphine? How much?
You give her morphine, yes.
How much? I mean, what was her weight? Was she obese? Was she?
I don't have the exact weight in her charts, but she wasn't obese. No, she was tall and slender.
75, 80 kilograms?
Like this, yes.
Yeah, 10 milligrams of morphine, but bear in mind that morphine has to be given very early.
Yes.
Okay? Even immediately after induction, don't worry about the baby. Because when the baby is delivered, it's still far away from its effect on the baby. So just give it beginning, because if you give it intramuscular, and give it intramuscular, don't give it intravenous. Give it intramuscular at the beginning of surgery. The time of the baby
actually,
out. Sorry?
Yeah, it's okay, Dr. Tariq, if you can finish. Yeah.
Okay.
Okay. Thank you for all the comments, but I think we can make a small group discussion later on after this webinar, because it's a very interesting topic and we can share more and more ideas about that. Thank you for your comments, all professors. But we really need to move to our last session, which is, as we said, best for the last. It is Professor Dr. Nesreen Rifai, Professor of Anesthesia and ICU and Pain Management, Caesarean Hospital, and one of our eminent colleagues sharing in more than anesthetic journal and more than one workshops. We all know her, and she will. Yes, can you please start, Dr. Nesreen?
Okay, I was telling Dr. Saad that we are already beyond time. I think everybody must be exhausted now. But it's okay if you want me to continue.
I'm sure we're all right with your talent. We can make it shorter presentation, and what is the most important. Thank you so much.
Go home before hearing you, Dr. Nesreen. It couldn't be. So please start.
Okay. Can you see my slides?
Yes, Dr. Nasreen, yes, we can see them.
Yes, yes. Thank you.
Is okay?
Thank you.
Okay. We're going to talk about obstetric anesthetic management for post-COVID-19 patients. First, we have to know some few definitions. Post-acute COVID-19 or long COVID is the persistence of symptoms 3 or 4 weeks after the onset of acute COVID. This syndrome is divided into 2 periods. Ongoing symptomatic COVID, which persists 4 to 12 weeks beyond acute COVID, and post-COVID syndrome persisting 12 weeks beyond the acute attack. The mechanism of post-acute COVID is not known, but it could be due to virus-specific pathological changes, inflammatory response to acute infection, or a sequelae of post-ICU illness. And this syndrome can occur even after mild initial COVID, so it hasn't to be a hospitalized patient or critically ill. COVID is known to cause a multi-organ system effect. It's documented in most body systems. Even autoimmune conditions can occur after COVID-19. The post-COVID conditions include cardiopulmonary, neurological, general symptoms, ENT and GIT symptoms, and even psychological disturbances. There is some management consideration for a patient in the post-COVID symptoms. It's a guide us to do for anesthesia. We have to review the neurological system. If we find peripheral neuropathy, then take care during giving neuromuscular blockers and quantitative reversal of the blockers. And we may think about avoiding regional anesthesia for medico-legal purpose. Cardiovascular palpitation or chest pain, this needs perioperative ECG, transthoracic echo, and cardiac consultation. Pulmonary functions, if we have restrictive lung disease, avoid general endotracheal intubation and go for regional, and take the consent of the patient that she may need post-operative ventilation. Hematological conditions, especially hypercoagulable state, needs pre- and intraoperative and post-operative thromboprophylaxis, and it's beneficial to use the enhanced recovery protocol to facilitate mobilization post-operative. Now we come to the real scenario. It's the cause why I thought about this lecture. The senior registrar told me that we have a list tomorrow with a patient coming for cesarean section. She was admitted to the hospital 2 weeks ago with acute COVID and high fever, and she was isolated and treated, and now she is okay, and the swab today, the PCR is negative, and they are coming for cesarean section tomorrow. So I didn't know what to ask about. Should we reassess the patient? Should we have the operation with the full PPE in the isolation theater or in the elective theater? So as we know, post-COVID can occur during pregnancy, and especially pregnant women with the physiological changes with pregnancy are more prone to respiratory infection because the large uterus expand upon the diaphragm, pushes the diaphragm up, leading to lung, limiting lung expansion, and it's a sort of restrictive lung disease and upper respiratory tract edema. One of the large researchers have included women in some of them, they were all had COVID, Some of them were pregnant and others were not pregnant, and they compared the two groups. They found there is a high availability of COVID in pregnant women more than the non-pregnant, and the pregnant women are more prone to critical illness, hospitalization, and mechanical ventilation. Actually, pregnant women are 1.5 times more likely to be admitted to ICU, and they are at increased risk of complication of pregnancy, preterm birth, and Caesarean section. But the evidence of vertical transmission of COVID is extremely limited. Vertical transmission means a transmission of infection from the mother to the fetus, which occurs either in utero through the placenta or intrapartum during vaginal delivery or Caesarean section, or postpartum as a part of droplet respiratory infection. A few weeks ago, all researchers said there is no evidence of transverse infection, but transmission of coronavirus. But just few weeks ago, the researchers found the amniotic fluid in the placenta of the infected mothers. Few of these mothers had PCR positive for amniotic fluid and placenta, which means there is possibility of transmitting infection to the fetus, and the neonates were affected. But these were only 3 or 4 cases among thousands of cases. Signs and symptoms of COVID and post-COVID are almost the same, but the most common during pregnancy were cough, sore throat, shortness of breath, loss of taste and smell, and some of the symptoms of normal pregnancy. So almost all pregnant have nausea and fatigue and dizziness. That's why the diagnosis of COVID in pregnancy may be delayed, because there is overlapping between the symptoms of pregnancy and the symptoms of COVID. Timing of delivery. COVID infection itself is not an indication for delivery, and COVID, if it occurs early in pregnancy, in the first or second trimester, there is no alteration to timing of delivery. But if it occurs in the third trimester, we just postpone delivery until we get a negative test. A Caesarean delivery should be based upon obstetric indication, not COVID itself. Caesarean is only indicated for pregnant women with severe respiratory distress syndrome. This is the only indication. Decision making regarding delivery depend on the gestational age, comorbidities, the degree of hypoxemia and rate of disease progression, response to therapy, fetal well-being. For example, a pregnant woman between 23 to 34 weeks, we have to detect the antenatal corticosteroids. And for example, if the mother at the 14th day of symptoms and she's not intubated and is doing well, she might improve with therapy. In this case, we don't have to go for Caesarean, just give the fetus choice to delay delivery. But if we have another scenario of patient, for example, at the 7th day of the start of symptoms, and she's already intubated now, this means most probably she will get worse. In this case, we deliver the fetus to save his life. Vaginal delivery for patient with COVID, we have to review platelet count, because 1/3 of patients with COVID have thrombocytopenia. Neuroaxial anesthesia is recommended for these patients, especially epidural, and we have to initiate epidural early. So at any time, if we have to shift for Caesarean section, we can just top up the epidural and convert to surgical anesthesia. Nitrous oxide is a kind of debate. Actually, some hospitals all over the world said that we have to suspend the use of nitrous oxide with suspected or confirmed COVID. While in UK, the Royal College of Gynecology, together with Obstetric Anesthesia Association, recommended using Entonox for vaginal delivery to relieve pain, but use single patient microbiological filter. Preoperative assessment should include clinical history of suspected or confirmed COVID, nature and severity of symptoms, timing and duration of symptoms, and other comorbidities. Physical examination, we have to concentrate on functional assessment and investigations, estimation of the effort tolerance, breath holding time, ambulatory oxygen saturation is very important. 6-minute walk test should be performed for all patients before cesarean section. Cardiopulmonary and nutritional status should be assessed and optimized if possible, and the normal labs. But what about PCR? Actually, PCR test can remain positive even after recovery, even up to 90 days of the onset of COVID. So we don't depend on it. It can be misleading. But if the patient came for a cesarean section after 90 days of COVID, for example, the patient had COVID in the first or second trimester, and now she's full term and coming for delivery, in this case we can repeat PCR 3 days before surgical procedure, because there is a possibility that she got another infection. Specific consideration for medication for patient with COVID during labor or postpartum period. Oxygen. Overall, the use of oxygen for fetal intubation for the fetus is controversial, because we use oxygen for the patient during face mask or high flow nasal oxygen, and both procedures are aerosol procedures, so they transmit infection to the OR and to personnel. Nitric oxide, as we said, is a kind of debate. PCA, intravenous PCA with opioid as fentanyl or remifentanil for labor analgesia. This case, we have to consider the risk of respiratory depression, so it's better to avoid using PCA with opioid. Non-steroidal anti-inflammatories are again a kind of debate, because non-steroidal, as we know, have ACE2 receptors which combine to the COVID virus. So it's said that ketorolac and other non-steroidals will augment the infection and increase the infection. So and increase the renal affection for the patient. So it's better to be avoided, while some authors say it's better to use non-steroidal replacing the opioid to avoid the respiratory depression. Regarding carboprostim, which is the first choice for the patient with uterine atony and postpartum hemorrhage, but this drug causes bronchospasm, so in case of COVID, it's better not to use carboprost, and we can instead use oxytocin or methylgene. Magnesium sulfate, as we know, we use it for patients with PIH, but keep in mind that for COVID patients, these drugs have central nervous system and respiratory depressant effect. So it's better to avoid using magnesium sulfate, except in extreme indication, patients with severe PIH, and we need to give magnesium sulfate to prevent seizures. In this case, we'll use magnesium sulfate in a dose of 4-gram bolus dose, and that's all. We don't give initial bolus and infusion. What about emergency cesarean section? Actually, emergency cesarean and exploratory laparotomy are the most likely emergencies that we face with COVID patients. Regional anesthesia is preferred technique when feasible because it has several advantages, as we know. But what type of regional? We can use spinal for cesarean, or epidural, or combined spinal epidural. And even the most recent research are talking about category 1 cesarean section. And we know category 1 means it's emergency cesarean section, and we need to deliver the fetus within 30 minutes. It's the decision to delivery time within 30 minutes. For these patients, we have a technique that started 2003. It's rapid sequence spinal. They call it rapid sequence spinal. In this technique, it's used for category 1 cesarean section, but this technique is not an individual technique. I can't take decision to perform rapid sequence spinal for the patient. It's a system that should be established in the labor unit and OR. So when we take decision of a cesarean section, we pre-oxygenate the patient from the start. Even in COVID patient, and especially with COVID patient, we have to do pre-oxygenation from the minute we took the decision. And we prepare the OR for both spinal and general anesthesia with all drugs and all equipment ready. And one of the team is assigned to put intravenous cannula and monitoring while they are transferring the patient to the OR. And the anesthesia should be ready in the OR. We don't scrub. We just wear the sterile gloves with no touch technique, and we use no touch spinal technique, which means the most expert anesthetist should perform the spinal without even feeling the vertebral column and detecting the space. He just omit the local anesthetic. We don't give local anesthesia. We go for spinal, one trial or at most 2 trials. If I'm sure that there is something wrong, I can correct it in the second trial. And we give local anesthetic with or without fentanyl. 25 mic fentanyl with local anesthetic. But in this case, in any other spinal for cesarean section, we limit the local anesthetic, the heavy Marcaine, to just 2 milliliter or 2.5 maximum. Local anesthetic or local anesthetic with opioid. But especially for this patient, the rapid sequence spinal, we can increase the dose to 3 milliliter. The whole volume can be increased to 3 milliliter. And we can, if you are sure that the anesthesia have started and the patient already have numbness and loss of sensation, at T10 we can ask the surgeon to start rapidly, even before reaching the surgical anesthesia at T4. General anesthesia for emergency cesarean, in case of failure of the spinal or regional anesthesia, we go for emergency CS under general anesthesia. And it can also be used in patients with decreased cardiopulmonary reserve. Induction agent, propofol or etomidate are fine for the circulation. Rapid sequence induction with rocuronium or saxamethonium. But for COVID patient, we don't like saxamethonium because these patients, even the post-COVID period, they have myalgia and rhabdomyolysis and loss of muscles. So it's better to avoid saxamethonium because in this specific patient, it may cause fatal hyperkalemia. Use high FiO2 until fetal delivery. Epidural combined with general is very good choice for post-operative analgesia, and we can use opioid, short-acting opioid as fentanyl, but we don't give the full dose. We don't give 200 or 300 mic from the start. In a COVID patient, we just give a top up of fentanyl to avoid sedation at the time of extubation, because at the time of extubation it should be awake in this special patient. Post-operative care, whether to shift the patient to the ward or to ICU, it depends on the availability of oxygen supplementation and the post-operative condition. Close monitoring of hemodynamic and respiratory deterioration. Some patients may need post-extubation CPAP or high-flow nasal oxygen. and good post-operative multimodal analgesia. TAB block is good. Post-operative thromboprophylaxis is a must. Then we have to discuss the thromboprophylaxis in these patients. As we know, pregnancy is hypercoagulable state, and COVID-19 infection may increase coagulopathy. That's why the National Institute of Health have published recommendation for COVID-19 pregnant patient. They recommended that pregnant patient hospitalized with severe COVID-19 should receive prophylactic anticoagulation. All pregnant hospitalized patients with COVID continue on thromboprophylaxis even 10 days following hospital discharge. We either use unfractionated heparin or low molecular weight heparin. Unfractionated heparin is preferred for the patient near time of delivery, patient who could deliver within 2 to 3 days, because it's easily to be reversed with protamine. If the patient is not expected to deliver within a few days, we can shift to prophylactic low molecular weight heparin. So in the COVID and post-COVID patient is most probably on antithrombotic or antiplatelet. What to do for as precaution for anesthesia? If she's on low dose aspirin, it's safe and there is no special precautions. If she's receiving low molecular weight heparin prophylactic dose, we stop it 12 hours before cesarean. If she's receiving therapeutic low molecular weight heparin twice daily, we stop it 24 hours before cesarean. A few cases of high-risk patient may receive clopidogrel or Plavix. In this case, if the patient is a high-risk cardiac patient with heart failure or cardiomyopathy, the clopidogrel can be stopped 5 days before cesarean and then continue post-operative. Low-risk cardiac patient with dual antiplatelet should be stopped 7 to 10 days before cesarean. But patients with coronary stent may receive aspirin and clopidogrel. It's a dual antiplatelet therapy. In this case, we have only with stent. We have to continue the dual antiplatelet, and in this case, we have to avoid regional anesthesia, and we go for general anesthesia. Direct anticoagulants are not routinely used during pregnancy, except in very few cases because it's not safe yet. For example, this patient on oral anticoagulant should discontinue 24 to 48 hours before surgery or cesarean section, but should be stopped 72 hours, which means 3 days before neuroaxial technique, and this is very important. Of course, if you have available thromboelastograph, it's the best that can provide coagulation status of the patient. But if after all these precautions we still have severe intrapartum or postpartum hemorrhage, and we have to administer fresh frozen plasma to stop the effect of the anticoagulant. Postpartum hemorrhage is common in COVID pregnant patient, and in this case, as we said, we don't use carboprost, we can use oxytocin or methergine. Tranexamic acid, tranexamic acid has pulmonary and prothrombotic manifestations, and the same goes for COVID-19. So the tranexamic acid can increase bronchospasm and increase clotting for the pregnant patient. Although we avoid using tranexamic acid for asthmatic patient, but for COVID patient, it's written in literature that we may consider tranexamic acid for postpartum hemorrhage, but it's still a kind of debate. We have to weigh the risk against benefit. Prognosis, the overall prognosis of these patients, the largest single database study of pregnant patients with COVID was published in the JAMA Network 2021 at August. They recommended that women with COVID had a peripartum death rate of 0.25 1%. The death rate and ICU admission is significantly higher among COVID pregnant patients than the normal pregnancy. Increased need for invasive ventilation and ICU admission, and they have severe symptoms and at higher risk for cesarean, preterm birth, PIH, and postpartum hemorrhage. And the worst outcome is, were in pregnancy with obesity, hypertension, or diabetes. Any questions?
Thank you, Professor Dr. Nesreen, for your very, of course, informative lecture. And we open the field now for questions for Dr. Nesreen. Any questions? Can I ask you a question, Dr. Nesreen? Of course, يعني, the lady is pregnant and everything, and she's going to deliver, but her fetus is now يعني, full term, for example. So, do you think sometimes we screen the patient post-COVID before anesthesia by doing a CT chest? Do you think we should do that or make it like a routine or put it in the protocol for anesthetizing cesarean section?
For post-COVID, if the patient has history of COVID during pregnancy, it is accepted. If she's already has COVID, it's again indicated that she should have CT chest, and we take the precautions to for the fetus. So we put apron over the abdomen, and we take shortcuts, and we limit the time of exposure to radiation. And it's written in the literature that there is a maximum radiation point. It's the unit, I don't remember the unit now, but we found that X-ray and CT, the normal exposure for investigations does not reach this critical limit of units of radiation. It's called a millirad, I think. So it's usually less than 5 millirad. So there is no risk for the fetus. So even for traumatized patient, we can do the necessary radiology.
And يعني, this is very nice. We heard it from you, and that you are telling us that it is already confirmed in the literature. Because I'm thinking not only post-COVID, if a patient, like she's really in the course of the infection now, and she just entered into labor, like an emergency cesarean section should be done for her. So again, I think if we make a pre-operative CT for this patient, at least we can categorize her like risk, high risk, and we can take the patient on intubated. We will not extubate after cesarean, and she can go. I mean, we can decide by the aid of the CT if it is so bad, we can take her intubated after her cesarean section to the ICU, for example.
Yeah, that's
it's good that it's good that we can. It's a very important.
Don't be afraid. You can go for a CT or X-ray. Actually, I've given anesthesia to one of our colleagues who had a car accident, and she was pregnant in second trimester, as far as I remember, and she had fractured femur, and surgeons had to operate and use the image. And they had to use image several times during operations. So I told them it's okay if it's emergency and you have to fix the fracture now. You can use image, but limit the exposure and take precautions for the fetus. And that was done successfully.
Another thing, if the patient is really in COVID or early post-COVID and she is going on the routine, in severe cases, the routine post-COVID therapy is to continue the anticoagulant, even if oral, like some people take it like 3 months post the COVID. So at that time, again, this will be our challenge. So for giving, regional for the cesarean, or better it would be GA. This is a debate because, again, this patient will be anticoagulated. So what is your opinion about that? PPT and INR, platelet and count.
The thrombelastograph is fine. Actually, it's not very helpful because for the oral anticoagulant, the reversal, the antidote for the anticoagulant is present, but it's not readily available, and we can't depend on the coagulation profile because the INR and prothrombin and all these investigations do not detect the effect of the oral anticoagulant, not quantitative or qualitative. So I can depend on them.
Yes, thank you very much.
That's why we have to take care when to stop them. Or shift, we can even shift the patient to Clexane or heparin and stop it 6 hours before the operation.
Yeah, you can bridge if it is like elective, but if, as we said again, the scenario is worse and
if it is emergency, so we can go for GA. But tell the patient that most probably she may need post-operative ICU and ventilation.
Yeah, I opened this point because I need all the audience to hear that from you. Thank you very much, Professor Dr. Nesreen. And if anyone would like to have a question.
I think Ahmed Samir raised his hand.
Everybody is happy by this time now. So I think it's time to conclude our webinar, Dr. Asmat.
Yes. Okay. I would like again to thank all our colleagues and our guest, our honored guest, Professor Dr. Gamal Lotfi, for sharing with us. Maybe this is the first time, I think, Dr. Nesreen, that the Scientific Obstetric Day have a guest from outside. And it was a very nice presentation from all of us. I would like to thank, again, the interactive session team for anesthetizing
it was very nice case, actually.
Yeah, and
I recommend they publish it.
Yes, it's very
nice case report.
Yeah, and actually we have many capabilities in the theater of the OB-GYN in Caesarean Hospital. But again, we're not like a tertiary hospital specialized in this special cases, and this case was really very grave in the disease. So I hope everyone enjoyed our sessions, and thank you for everyone. Thank you for Dr. Saad. Thank you for Dr. Magid. He was the link between us and Dr. Saad. And of course, we were honored by the introduction with our Professor, Chairman of Anesthesia, Dr. Mohammed Abdul-Raouf. Thank you, everyone. And thank you for the attendees for the attendance and even for the questions.
Thank you, Dr.
And would like to meet you. Yeah, thank you very much, Dr. Saad.
Thank you very much. Really
actually, I just want to give one comment. Honestly, Dr. Saad, I'm a member of Education Committee of World Federation Society of Anesthesia, and we are publishing our journal, the update. It's a free journal, peer-reviewed, and assigned to write an article about remote learning.
Fantastic.
The online learning, and So I found that all points for successful remote learning is really present in mega course. I even have written mega course as a reference.
Oh, thank you so much. I would be so grateful.
I told them we already share the remote learning, and it's attended by thousands.
I would be so grateful to you if I have a copy of that reference, please.
Sure, we are reviewing the articles now. It will be launched and published online.
That's so kind of you, Prof. Nasreen. Thank you so much. Thank you.
We are really happy, and we are blessed by having all these professors and assistant professor speakers. And it was maybe the first time that we allow a senior resident to share with us, but because they were excellent in reading about this case and preparing and managing.
Well,
thank you.
Actually, it was very interesting discussion, you know, and as I told you before, Prof. Nasreen and Prof. Asmat, I shared my opinion with Prof. Magid Sarah early 1 year ago, and we see people who are working very hard exactly in the front line, like people. It was initially for Egypt, but now we are more than 80 countries all over the world just to get benefit from this webinar. Our aim is just a small hospital in the end of Egypt, you know, at the periphery. They are not sharing the same experience or not working with the same professor like Prof. Asmat and Prof. Nasreen. At least they have a chance to listen to them, to get the experience. People are working in Marsa Matruh, they will never see Marfan syndrome, and they don't know even how to deal with that case presentation. How are we going to do with the COVID, the pregnant COVID, like Prof. Nasreen mentioned? 2 weeks ago, one of my colleagues from Turkey was looking for a reference. So I just give her the lecture of Dr. Professor Nasreen Rifai, and she sent me an email. Thank you so much for that. That's absolutely fascinating help, you know. Those lectures, if you go to any conference, the lecture is given and gone. But here, the lecture is given and staying for learning and teaching for forever, inshallah. And thank you very much for everyone
very much.
supporting us tonight. We have 230 people attending this webinar, and may Allah thank you all of us. Thank you.
Thank you very much,
Dr.
Sa. Thank you.
Thank you.
Thank you.
Thank you, Professor.